Good evening, everyone. I think so. I already mentioned to you earlier that we are going to start with two classes for the evening today. One is interpretation of a culture sensitivity report, followed by the pending class on drugs, that is your antibiotics. Okay. So this is one of the questions that will be asked to you in your data interpretation station. Okay, along with what we have already previously covered. So here we would like you to understand about what are the basic standard terms that they'll ask you regarding a culture sensitivity report and how to approach a culture sensitivity report and what are the pitfalls that are there when giving you a report and which you guys have to pick up. Okay, not everything will be straightforward in a culture report. Okay, so that is what we want you to understand and learn in this session. Okay. Like the previous classes, you are free to unmute and answer. This will be a Q&A in between, okay, because we are dealing with practical sessions. So firstly, there are two culture sensitivity reports here, one on the left and one on the right, okay? So Mr. Dummies is on the left on my side, and then there is another report as well. So do you think both the culture reports are similar or one is superior over the other? Can anyone unmute and answer? If you don't answer this, then it will be straightforward. I'll just keep talking. So which is better among the two? Okay. I'm
Sir,
sorry.
the
Yeah.
Clostridium tertium one is better. I mean,
Oh,
it's more
oh.
sensitive as compared to the one with E. coli. E. coli, actually,
Mhm.
but if you look at the colony count, the colony
Mhm.
count is only CFU 100 CFU per ml.
Mhm. No, no, no. I'm just telling which reporting is good. We are not going into any specific details. Okay. Which type of reporting is better? The one with the Clostridium tertium or the one with the E. coli?
Hmm.
The
Sir,
Is
one with
one
the
super?
Clostridium
the
tertium is better as it is showing MIC interpretation.
Okay. So you guys want to go ahead with telling that this is better than the other. Okay. So keep your answers for yourself. We will come to the answer in the later slides. So then you let me know. Okay. Whether you want to change the answer or not. Okay. So whenever you get a report like this, right, sensitive, resistant, intermediate, etc., what does it mean? Does it mean that if S is as sensitive as that, you can directly go ahead and give the thing? Or resistant means you should never use that antibiotic? Or intermediate means you have to do some jugaad? What do you guys do? You're doing this only, right? On daily basis, you're getting a culture report. You're going to act on this culture report based on these three things, correct? Resistant, intermediate, sensitive. So
yes,
whenever so what is your understanding of it?
sir, sensitive is there is in vitro sensitivity that has been found.
Okay.
Intermediate is in some of the samples it is sensitive, some of them it is resistant, whereas
Okay.
resistant is in vitro it has been resistant, but not necessarily that means the in vivo scenario will be resistant as well. Sometimes even resistant bugs respond to uh, the antibiotic in vivo,
In
provided
vivo.
if we match their PKPD properly.
Okay, good. One of the thing is PKPD. Along with that, there are certain other factors like dose, etc. Okay, so resistant and intermediate, yeah, the changes can happen when you have these concentrations of drug and the PKPD principle changes. Good. Sensitive, as simple as it, you can at least use this drug, being sure that this will definitely have some bactericidal activity or static activity based on what is the type of antibiotic that we are going. So this is what is the basic understanding, correct? So if you have multiple susceptible or sensitive drug, which will be the best drug to take forward and go? So here in the previous one, you have penicillin, piperacillin, ceftriaxone. All three are there, which is sensitive for Clostridium tertium. Okay. So including a carbapenem like ertapenem, and which one will you choose? Is there a way that we can go about, or you will directly tell that this patient is sick, the patient is in ICU, I'll use a carbapenem?
The one with the lowest MIC.
One with the lowest MIC. So does that mean that lower MIC means it is a superior antibiotic to the other antibiotic? That is what your understanding is, correct?
Yes, sir.
Okay. So most of the things are firstly, okay. I'll answer these questions now so that you don't have confusions later. These two are not separate. Okay. These both are equally good reports. Okay. You cannot tell one is superior over the other. Basic understanding is the way they have been reported. Okay. One is using a broth dilution. Okay. The one with the Clostridium tertium is using a broth dilution method to give you the answers. The other one is using a disk diffusion or the Kirby-Bowers method. Okay. So both are standardized, both are acceptable reports. One is not inferior to the other. Okay. That answers the first question, telling which is superior over the other, whether they are comparable or not. Okay. Then comes the second question. I asked you RIS. I think so fairly enough. S, you can understand and go ahead. And R and I, depending on the PKPD principles dosing, we can think about it. R, majorly no, but if you're left with no options, only then we have to go with the combination therapy, wherein R drugs also can be used. That is, resistant drugs can also be used. Okay. So that is the second question. The third question I asked you is, there are multiple susceptible antibiotics here. How do you choose which one? So one of you answered telling that whichever has the lowest MIC will take. But here what happens is you're comparing two different classes of antibiotics. So their MICs will obviously be different. Okay. So you cannot take MIC alone for that particular antibiotic and then tell this is superior over the other, because you're not comparing equally. You're taking two things. You're taking an apple and an orange and telling these two are, this is apple is superior over orange. On what characteristics? Based on the number there, which is actually not equivalent for both of them. Okay. So if you have understood these things, we'll go to the next part of it. Okay. Am I clear now? Any doubts in this? Okay. So what do we want from a culture sensitivity report? A culture sensitivity report is it will give you one answer. That is, at standard dosing, is that particular antibiotic likely to achieve an effective concentration at the infective site for that particular organism. Okay. So you have to look at the standard dose, the concentration at the infection site, and whether it is effective against that particular organism. If these three or four things are included, only then you'll have some effect from the culture report. Okay. Otherwise, probably any one of this is missed also, your clinical outcome will be bad. Okay. So it does not always mean that this drug alone will cure the patient. Okay. There are few things like resistance mechanisms which can be skipped or not being reported on the culture sensitivity report. Okay? So this is something that we need to reassess and then I understand. Okay. Sometimes, like we have mentioned, resistant need not always mean it will not work at all. Okay. So sometimes you might have to look at the concentrations of the drug, higher doses of the drug, and then come to an clinical management. Okay. So this is what we want you to understand from a culture sensitivity report. Okay. How are culture sensitivity reports generated? I told you earlier, there are 2 ways or 3 ways. Right now, there are multiple automated techniques also available, but just a small class in microbiology here. Okay. So just to know how it happens, basically they have multiple antibiotic discs here. Okay. So they'll place an antibiotic disc on a culture plate, and then they'll have an isolate here, right? There is their organism which is growing. So based on that, whichever culture plate has a maximum zone of inhibition, we will take that antibiotic to be susceptible. Okay. That again will be quantified and they will let us know. That is what the microbiologist's work is. So this is one way of doing it. The other one is your microbroth technique. Okay. So there are basically these currently available techniques for antimicrobial susceptibility testing. That is your disk diffusion, as I showed you here. The other one is your broth or your agar dilution. The other one is your epsilometer test, and you have the automated AST or your Vitek Phoenix machines, etc. Okay, so all of this will help us understand which antibiotic and all your numbers which you get with MICs, right? This is based one of these techniques. Okay, majorly what happens is disk diffusion will not give you that number, but it can be interpreted by various other tools. Okay, there are linear regression analysis which they do based on the zone of inhibition, and they'll give it to you if at all you require it. Okay, but by and large, whenever you have a disk diffusion method, you won't get that. Okay, based on this, they will take a caliper, okay, and then measure it, and then let us know what is the zone of inhibition, which is the largest zone of inhibition, and then probably you will be able to understand which antibiotic is better here. Okay, so this is what they do. All the colors in the KP BOS plate, whichever is present here, is different antibiotics for which we are checking the antimicrobial susceptibility testing. Okay, so I told you the other one is your broth dilution technique, correct? So broth dilution technique is what they do is they'll have two controls, and serially they will dilute the broth in a petri dish, or not a petri dish, I'm sorry. You will have a multiple small test tubes, or you'll have a cassette. Okay, on the cassette they will have serial dilutions which are placed, and then the organisms would be placed in each of these solutions. Okay, so based on the clearance of the organism at one particular concentration, that will be taken into understanding that this antimicrobial is working at this particular concentration. Okay, first it will flag it, and after flagging it will tell us at what concentration the antimicrobial effect is better. Okay, so whenever we are getting MIC directly, majorly it will be from your broth dilution technique. Okay, so right now, because it is all labor intensive, we have this Vitec machine that does this. It has a cassette, it has multiple wells. Okay, and then each well will have its different concentration of the antibiotic, and then we can come to an understanding as which concentration the antimicrobial effect is good for that particular antibiotic. Okay, so I told you disc, there are different types of antibiotics, and different types of antibiotics, different zones of inhibition. In broth dilution, it's the same antibiotic at different concentrations. Okay, so if you want for penicillin, you have to do a different broth dilution. If you want for carbapenems like meropenem, you have to do a different. Okay, so similarly, each of this will have a different cassette and different concentrations. Okay, so in the disc, on the contrary, it is what happens is there will be a predetermined dose of antibiotic in that particular disc when they're taking. Okay, so what they take from the dispenser, they'll put that predetermined concentration, and based on that concentration, whether there was an antimicrobial activity present or a zone of clearance which was achieved, is what they will check. Okay, so this is the basic understanding of classification of antimicrobial susceptibility testing. Similarly, you have something called as the E-test or epsilon meter test. Majorly, they are being used for your newer antibiotics like your ceftazidime, okay, or your combination of zavicefta like ceftazidime, avibactam, or for synergy testing. Okay, all of this is one thing that we can use these susceptibility testings. Okay, so earlier I was talking about broth giving us an idea and telling us whether it is susceptible or not. So one of you can ask me the first thing I showed you, the culture sensitivity report, correct? So here there was just what was here. It was only the antibiotic and sensitivity. It says only sensitive, resistant. Okay, it does not say what is the MIC, correct? So I told you for MIC in a disc diffusion, you need to do something called as a linear regression, and then they'll give it to you. Otherwise, it's not required. Okay, you can just directly go with this understanding. So if at all you need to know which is a better antibiotic, you need to call the microbiologist and then decide which is the better choice. Okay, so this is about one of the drawbacks of disc diffusion, but it is not inferior to broth dilution. Okay, so how do we come to that resistant intermediate susceptibility? So usually this would be given by the CLSI or the UCAST guidelines. Okay, so it will tell us what is the zone of inhibition, and that would be measured by the calipers that I showed you earlier. So based on that zone of inhibition, it would be categorized as resistant, intermediate, or susceptible. Okay, so if it falls under one of these categories, then the antibiotic would be labeled as resistant, intermediate, or susceptible. Okay, so coming to MIC. Okay, I told you microbroth dilution techniques. You will have serial dilutions, and one dilution you'll have the clearance. So can anyone tell me what is MIC? It's there on the screen if you guys want to read it out as well. So how do you define MIC? See, MIC is something that you guys have to answer when they give you a culture sensitivity report. What is MIC?
The lowest dose at which 50% of bacteria growth is inhibited.
No, it's not 50%. It's visible growth of the bacteria. Okay, you see here Okay, so MIC stands for the lowest concentration of an antibiotic that prevents visible growth of an organism in a laboratory setting. Okay, so here again you have 10 test tubes. Okay, and here serial dilution of the antibiotic would be placed from 1 to 7. Okay, so when you have the series of test tubes and they have multiple concentrations of the antibiotic, firstly they will introduce one and microbial here. Okay, the same isolate would be present all over here. Okay, so as you can see, the turbidity or the uh, darkness of the blue shade comes lighter towards 5, and it becomes completely absent or very clear in 6. Okay, so at this particular concentration there is complete removal of that particular pathogen from the test tube. Okay, so that is the reason that becomes the minimum inhibitory concentration that was required to completely clear the isolate from that test tube. Understood? So that is what MIC means. Okay, it should be the lowest concentration of the antibiotic that prevents visible growth of microorganism. So why we are telling it is lowest? Because even in seventh test tube also there is clearance. Okay, but that is not the lowest. At 6 itself you have a visible clearance which is seen. Okay, so that is the reason it will be given as that particular concentration. Okay, so you need to understand that earlier one of you told, right, MIC low means that is a better drug. Okay, it is not like that. Okay, because these numbers can be different for different antibiotics. That's the reason you cannot compare MICs across different antibiotics, because each antibiotics concentration, dosing, everything will be different. Okay, one will be in grams, one will be in milligrams. Correct. So all of this matters to us when we are talking into consideration about the concept of MIC. Okay. So is it clear till now? So now why you cannot take lower MIC in the culture sensitivity report as the best antibiotic? Any doubts till now? Okay. So what is a breakpoint? Now if you've understood MIC, what is a breakpoint? See, this is a commonest question they will ask you. Okay. What is MIC? What is breakpoint? Okay, so breakpoint is the one which will tell you whether that particular concentration falls under the sensitive range, intermediate range, or the resistant range. Okay, this is not different for for one place, and it is if it is India, this is one value. If it is Germany, it is different or something like that. It is not like that. Okay, it is universally set. This is the reason it will be given by an organization like your CLSI or your UCAST. Okay, these are the people which will determine which specific MIC value after which the antibiotic turns out to be resistant, or at which particular MIC value the antibiotic can be deemed as sensitive. Okay, so earlier when we talked about this, right? So resistant, intermediate, susceptible, we give them numbers right here, 13, 14, 22 or 23 for erythromycin. Who gives this number is by CLSI or UCAST. This is going to be revised every year. Annually, you are going to have this. Okay. And this is going to be based on multiple reports all across the globe. Okay. Majorly, it is biased because it might be from the Western data, but then at least you have a yardstick of measurement and you have some sort of standardization. Okay. So breakpoint is the MIC at which you can categorize the antibiotic as being susceptible, intermediate, or resistant. Okay. Am I clear till now? Okay. Any confusion still now? Okay. So I was telling you earlier, right? So UCAST, CLSI, all of them have these tables. Okay. They'll be giving it for all the agents. Okay. So if you can see here, there is one zone diameter breakpoint that will also be termed as sensitive resistance or area of technical uncertainty or intermediate. Similarly, you have your broth dilution technique also, that is also going to be categorized as sensitive resistance or area of technical uncertainty. Okay. So this is one way how that chart or that PDF comes like. Okay, so every year it is going to be validated and it has to be kept in check. So usually this will be available with your microbiologist, they have to know it. Okay, and sometimes it now with automated machines, they are going to be fed into them so that they understand what is the cutoffs. Okay. So if you're taking one particular example, here we have enterobacterials. So if you see disk diffusion, what is the disk content in micrograms and zone of diameter, and based on this you will get the culture sensitivity report breakpoint telling that it is sensitive, resistance, or intermediate. If it is broth dilution technique of AST, you will get it based on these numbers. Okay, so this is how it is. So breakpoints is that particular MIC which categorizes the antibiotic to being sensitive, intermediate, or resistant. And breakpoints are usually given by standardized laboratories, majorly by two major authorities, that is your CLSI and UCAST. Okay. So, whenever you get a culture sensitivity report, this is what you see, right? Earlier also we saw that culture sensitivity report. It had a list of antibiotics. It gave a organism. It told a source of the isolate, and then you have an MIC, and then you have an interpretation. Correct. So with this, can we go ahead and tell which is better or not?
I would like to know the breakpoint.
Very good. Okay. So this is what we look at. So based on what breakpoints the interpretations were given to you. So excellent. I think so you have understood whatever I've tried to convey in the previous slides. Okay. So you need to compare this breakpoint to categorize that antibiotic as being susceptible or resistant. Okay. So for example, let us take ceftazidime in this example. Here the MIC from the isolate, that is from the patient in the ICU, was found to be 32. So the breakpoint given by CLSI or UCAST is if it is equal or more than 32, you need to categorize it as resistant. So that is why the interpretation comes as resistant. Okay. Similarly, if you take imipenem or meropenem, both are sensitive. That is because the my MIC value of these two fall in the susceptible range of breakpoint. Okay. So is that understood till now? That's very straightforward and easy to understand. Correct. So I think so. You now understand MIC is from that particular pathogen of the patient, but breakpoint is universally given by a agency like CLSI or UCAST. So the next question would be, if so many are susceptible, which one to take into consideration? Any answers? So you have imipenem, you have meropenem. Okay, both are carbapenems. So now I can ask you, right? I told you earlier you can't compare apples and oranges or two different classes of antibiotics. Now we have the same class of antibiotic. Now would you choose imipenem or meropenem?
So we
Based on
will.
the site of the
Or you will choose?
infection. Site of the infection.
Sorry, site of the infection. So I think so if you see carbapenems, by and large both of them are having equally good cover, right? That's why I didn't take ertapenem as an example here. So if I'm taking meropenem and imipenem, they're fairly good antibiotics with, say, almost similar areas of coverage,
So we will
sites of
go.
coverage.
We'll go with meropenem. But sir, we can also, in this case, we also use cefepime?
So you can use, that's a good question. So now you're getting confused, right? इतना सारा susceptibility patterns है, किसे choose करें? So how will you objectively tell? Okay, so there's something called as a susceptibility index. Okay, so this is something that I'll teach you in the later classes, I mean later slides, so that you'll understand which antibiotic to choose. Okay, so this is something which is based on a calculation of your MIC and your breakpoint. Okay, so it will let us know which is the least susceptible antibiotic to develop resistance when you treat this patient. Okay, so that antibiotic can be chosen. Okay, that is what is this BMQ. Okay, so I'll teach you this later. I just wanted you to have this confusion so that you'll have an answer to that later. Okay, your understanding, you can treat with cefepime, you can treat with peptides, you can treat with meropenem and imipenem, but in these things which one to choose, that is what I wanted to understand. There is a way to do it. Okay, that way is called as susceptibility index. Okay, I'll teach you in the later slides. Okay, so now do you guys agree that both the things are equally acceptable? These two slides, I mean these two tables, reports. So one is on disk diffusion, other one is on MIC. It can be accepted, right? And interpreted. Okay. So now we have a 70 kg male patient, in the ICU with septic shock and bacteremia. The organism isolated was E. coli. Okay. So this is the AST report. So what would you do?
Will we prefer gentamicin?
You'll prefer gentamicin. Okay. So this is one thing I just wanted to understand about that susceptibility index. Okay. So when we do susceptibility index, right? So we take MIC versus breakpoint. You divide it. Okay. So when you divide it, whichever has more MIC which is available. Okay. Like for example, two more dilutions which can be present at that particular time, you take it. Okay. So gentamicin, as you guys told, it is actually a good drug. Okay. Because again, the breakpoint which is referred as 4 here, but the MIC value is 2. So 2 serial dilutions would be required to gain resistance here for that particular antibiotic. So that is one of the reasons gentamicin comes into understanding. Okay. So probably here it is good. But again, just using gentamicin, I would be skeptical. Probably piperacillin tazobactam, even though the breakpoint is 16, the whole thing is whatever we do, MIC is in micrograms per ml. But the dosing of piptaz is what? What is the standard dose of piptaz?
4.5 gram IV 8 hourly.
So it is in grams, right? So usually, this is what I want you to understand. If here your breakpoint comes as 16 and it's still susceptible, it is not inferior to gentamicin. Okay, that is because peptides will be dosed in grams. Okay, so that is the reason it is equally efficacious as compared to gentamicin. Okay, so here, it being a gram-negative organism and a bacteremia, you can still think about using a broad-spectrum antibiotic like a piperacillin tazobactam, okay, against gentamicin alone. Okay. So what is minimum bactericidal concentration? See, 3 definitions they will ask you: MIC, breakpoint, and MBC. So what is MBC? It's there, okay? It's the lowest concentration that results in 99.9% kill rate in a patient who is in the ICU, especially with patients having privileged site infections like endocarditis or meningitis, okay? So remember, it is the lowest concentration which causes 99.9% of kill rate in the target site. That is your, be it endocarditis or meningitis, okay? That is what is MBC, okay? So whenever we have interpretation of results, okay, you need to have 5 core components. That is, firstly, you have to know what is the sample source, what is the organism identified, what is the antibiotic panel which has been tested, what is the quantitative result, okay, that is your zone diameter if it's BD or MIC if it's your broth dilution, and then interpretation category, okay. So sample source can be blood, urine, bile, ET aspirate, okay. So antibiotic of choice depends on site of infection and site of isolation, correct? So that is very important because you need to differentiate between pathogen and colonizer. Then you have to have a species of identification, okay, especially when you have your enterobacter, okay. So fish usually if you don't, and fungal infections as well, okay. So you need to know the particular species as well. If you just know Candida species, probably you will not be able to treat it accordingly, okay. So antibiotic panel which is being tested, you need to know sometimes not all antibiotics gets tested, okay. So usually depending on the source of which the isolate was taken from, based on your local antibiotic policy, only those group of antibiotics would be tested, okay. So usually absence of antibiotic should not be considered as resistant to the antibiotic, okay. So then based on those techniques I told you, you will have your MIC or your zone of inhibition, and then you can get your breakpoint like susceptible, intermediate, or resistant, okay. So this is what you earlier saw, right? So first you have the source, then you have the organism with the species, then you have the list of antibiotics, then you have the MIC value, and then you have the interpretation. These are the 5 basic components in a culture sensitivity report. Okay, so whenever you're answering in the exam, you need to go like this. Okay, you need to tell it's a blood culture report of a Clostridium tertium. Okay, and the interpretation you can then start by looking at the MIC values, breakpoints, etc. Okay, so basically you need to tell where it is drawn from and what is the organism, and then you can talk about your culture sensitivity based on your antibiotic profile which has been given to you. Okay, so by and large, you guys told it correctly when you told about susceptible, intermediate, and resistant. Susceptible means there is a higher probability of treatment success, but it does not always guarantee success. Okay, you guys know that. So you have treated a lot of patients, even though you're given susceptible antibiotics, they might be not having a clinical outcome. Okay, so does it mean that the antibiotic was at fault? Maybe not. Probably there might be issues with dosing, PKPD principles, or some other newer resistant mechanism which was not picked up at that particular time. So susceptibility just tells that that particular antibiotic has a higher probability of treatment success. Resistant again means a lower probability of success. Okay, so at that particular time, probably a combination therapy would be helpful. Okay, intermediate again, it's a buffer zone. Okay, so mostly you guys refer to colistin, right? So colistin, majorly why they give it as intermediate is because you need to know where is the site of sepsis or where is the isolate taken from and what is the particular MIC. Okay, whether any change in doses can cause a treatment failure, especially when you're dosing colistin in patients with CKD or patients on ECMO or patients on CRRT. Okay, so that is the reason we need to think of a lot of other reasons when we are giving I as the breakpoint for that particular antibiotic. Okay, so if at all we need treatment success, especially when we are taking intermediate as the breakpoint, you need to probably increase the dose, change the regimen, and look at the site of sepsis. If we are able to look at all of this and correct it or adjust our antibiotics properly, then we are going to push that intermediate towards a susceptible group. If at all we fail to do so, then it will shift from susceptibility to resistant and probably will have a treatment failure. Okay, so let us take one example after understanding all of this. Okay, so we now have 3 patients with us who has grown Pseudomonas aeruginosa. I am checking the sensitivity or susceptibility to tobramycin. Okay, so no need to think about why tobramycin, etc. here. Just answer based on whatever you see. In example 1, the MIC of this patient is 2. Okay, in 2 it is 8 and 3 it is 16. Can you just by seeing these numbers give me an answer whether the effectiveness is present or not?
No.
Okay, you want what? You want a breakpoint, right? So this is the breakpoint. So now can you guys guess which is going to be effective, which is going to be ineffective? This is straightforward. No, this is very easy now. You have an MIC of 2 in example 1 and the breakpoint is 8. So is it going to be sensitive or resistant? Okay. See, definitely whenever you have the MIC being less than the breakpoint, it's going to be sensitive. Okay. So whenever you have the breakpoint and MIC close to each other, it is going to be called as intermediate. Whenever you have the MIC being very higher than the breakpoint, it's going to be labeled as resistant. Okay. So that is the reason probably 1 and 2 might show some effectiveness, but definitely example number 3, there might be no clinical positivity if you treat this patient with tobramycin. Okay, is this clear? Now you understand how we'll label it as S, I, and R, sensitive, intermediate, and resistant. Okay. So I wanted to give an analogy, but I feel you guys will get confused with that. Okay. So remember, there are a few assumptions in antimicrobial susceptibility testing. Do we test all antibiotics for all samples? If we are not testing, then how do we decide
No,
whether?
sir. There are
So
some
how?
intrinsic resistance.
Okay. So intrinsic resistance, okay, it depends. That's another set altogether. Okay. So what we usually do is, again, these are not decided by me, you, or any other clinician who's going to be sitting there. Okay. So this is again by the two major agencies. Okay. They have decided there will be a certain set whenever there is a particular organism. Okay, for example, if there is enterobacteriaceae growing, right, there's a general pool of antibiotics that they will take into and run all these antibiotics in the tests that I mentioned, either a disc diffusion or a white tech or etc. Okay, so again, in this is general. But again, if you're looking at urinary issues, they'll look at a urinary panel of antibiotics. If you're looking at blood, they will have a blood panel. Okay, usually this is how it is fed into those systems, and that is how we get. Okay, there's a predetermined set of antibiotics for that particular pathogen, and that is how it is going to be coming across. Okay, that is the reason whenever I ask you a question, do we test all antibiotics for all samples? No. Majorly it depends on the type of organism and the site of organism. Based on these two, the most commonest antibiotics which are effective at those sites would be tested. Okay, and these would be given to the labs predetermined. Okay, so that is the understanding. Intrinsic resistance is definitely there. That is something that we need to deduct out of the report, but it is not going to be mentioned there like this. Okay, and obviously if it's not going to be always absent. Okay, few labs which are not standardized can still have those agents present there, even though there are intrinsic resistant to them. Okay, ideally they have to mention it. If it's a best lab, they will mention it that this is intrinsic. They will show it as susceptible, but then they will mention it as it is intrinsically resistant. Okay, similarly there are drug bug reporting. This is what they call it as. Okay, so they'll have one particular set of antibiotics for that particular bug, and that is how it is going to be tested. Okay, so this is what I wanted you to understand. The take home is not all antibiotics would be tested. It's only going to be done on site and type of organism. Okay, so again, whenever you get a report, no, there is something called as cascade reporting. That is usually first line will be the ones which is resistant or intermediate. Okay, the second line will be the ones which is having some sort of closely related sensitivity to this patient. Okay, and then the third line options would be given. Okay, so this is how they are going to be placed, and this is something that they will decide based on multiple reports which come to that particular lab. Okay, so if they ask you how are they placed, just tell them that is based on cascade reporting. Okay, so why we need to know all of this is because there's a lot of things about access group, watch group, and reserve group. Okay, this is one more question that the examiner can ask you. Okay, so majorly whatever antibiotics you're using in the ICU right now fall under the reserve group. If you can remember that, I think so that is good enough. Okay, so if you see your carbapenems, okay, your glycopeptides, your monobactams, okay, all of this, even your third generation cephalosporins like your ceftazidime avibactam combination, all of them come under the reserve group, especially because of the increasing antimicrobial resistance. Okay, so if they ask you, are you aware of the WHO classification of antibiotics? This is what you need to tell. Okay, they are categorized as access, watch, and reserve. This is WHO classification. Okay, so let us go to a few examples. Okay, so are you guys clear with what is sensitive, intermediate, etc.? Resistance, how do we do, what are the classification? Anything that you guys want me to repeat if you have not been clear about? It takes a little time to understand. That's the reason I'm asking.
Sir,
Yes,
hello.
please. Yes, please tell
Sir,
me.
I wanted to ask one question. If the MIC by breakpoint ratio we are taking is 4 and is 1 is 2.
Can you please repeat that?
MIC by breakpoint ratio we are taking,
Uh-huh.
it's 1 over for 1 it is 2 and 1 it is for 4.
Mm-hmm.
So what is the meaning of that 4? Whether this is having more room, I understand the analogy, there is more room, but what is like the exact meaning of 4? How much half-life we going to get resistant or what?
Excellent question. That is the whole idea. Okay, the higher the number, the better the chance. And what you understood also is absolutely correct. Okay, whenever you have a more number, right, like 2 and 4, you are taking into consideration. So 4 ka matlab ye hai, there is some more room for that particular antibiotic to develop resistant Okay, so usually what happens, MICs, when they change, is usually because of development of resistance. Okay, so that is what you're trying to look at. So if at all it develops resistance also, it is going to be at that particular concentration of the drug. Okay, so whenever we are doing the susceptibility index, higher the quotient, better the antibiotic, because there's a long way to reach the resistance for that bug. Okay, so it will remain in the susceptible group for a longer time. Okay, I will show you an image later on. I have an example, you'll understand it better. Okay. Okay, so let's start with first case. We have a 30-year-old patient who presents with fever with chills since 3 days. After examination, the physician runs some routine blood tests and culture reports. It's going to take some time. Okay, so how would the patient get his antibiotics here? What would be your antibiotic policy?
It will depend on the source localization.
Excellent. Then
Local
site.
antibiotic.
Basically, you're telling site, right?
Yes.
Okay. Then site. Then
Then
Local
depending
antibiogram.
on
very good. Local antibiogram. Then
then history of any recent hospitalization or
very
any
good.
invasive procedure or if they are present.
Okay. So good. So these are the things that they will also anticipate you're looking at. Okay. So you have to look into all of this, know where the site is, whether it is respiratory issues, whether it is abdominal issues, it is urinary issues, or it is CNS issues. So based on this, how would you choose? So in this case, for example, if the patient had cough, so what would you start this patient on? Cough with expectoration, with fever and chills. So you don't have the cultures, but you have to start this patient on an antibiotic because he's having high grade fever and definitely he's on some oxygen requiring, his SIRS score.
Yes.
Sorry.
Sir,
As the patient is having fever with chills and cough, I will suspect the community acquired
Hmm.
pneumonia. So I will go ahead with the
Good.
macrolide third generation cephalosporin.
Very good. Okay, so this is what I wanted you guys to answer. So unless you get a culture sensitivity report, you need to start empirical therapy. And empirical therapy should be based on whatever things you guys mentioned earlier. It should be based on your site, your local antibiogram, the recent whatever is going on. Probably if the patient is like what I told, previous history of hospitalization, whether he's on dialysis, whether he's immunocompetent or compromised. Okay, these are the parameters that you need to look into and initiate him on a probable broad spectrum antibiotic. So good, you told macrolide versus with the cephalosporin combination, that is your third generation. That's a good enough thing. But use terms like broad spectrum antibiotic based on these things. Okay, that is the answer we are looking at for this question. Good. Okay. So usually you need to remember what are the broad spectrum and narrow spectrum. Okay. So you need to know what are atypicals, what are the covers for gram positive, gram negative. Okay. So this is something that I'll be dealing with briefly when I talk about antibiotics, but you need to know what are broad spectrums. Okay. For easy understanding, your third generation cephalosporins, your BLBLIs, your carbapenems, you can take them as your broad spectrums. Okay. Along with a few group of penicillin drugs again, but it's not all the groups. Okay. So you need to start with this and then probably de-escalate on culture arrival. Okay. So let us take this case number 2. Okay. You're doing your rounds. Your junior doctor comes and complains that the microbiologist has foolishly ignored to add ceftriaxone to this culture sensitivity report. Okay. And the culture sensitivity report is showing a growth of MRSA, that is your staph aureus. So what is your answer to this? You have your junior doctor or junior coming to you and telling this. Should we call the microbiologist and ask him why you didn't put this ceftriaxone?
No,
Or
sir.
what is the concept that I'm trying to ask here?
As the patient is having oxacillin resistant, so it is considered as a methicillin resistant Staph aureus. So there is no
Right.
question about the ceftriaxone. We can go ahead with the vancomycin or any other drugs. Like
Very
if
good. Okay, good. What is this called as? You clearly told the oxacillin resistance is there. Okay. So usually for MRSA, what is the thing that we use? MRSA is called as methicillin resistant staph aureus, right? So there is no methicillin here, but still we are calling it as an MRSA. How
sir, cross resistance.
is it cross resistant or we call it something else? Okay, use something called as a surrogate marker, okay, for methicillin resistance. So usually most of the labs use cefoxitin, okay. So this is one thing you need to understand. So you might not have methicillin there to call it as MRSA. So this is something that we need to understand, deduce from these, okay. So you guys clearly picked it up, okay. So what I want you to understand is cefoxitin, if it is showing as resistance, it is a surrogate marker for methicillin resistance. Here, if it, even though it is not given, oxacillin will give you an idea whether this is a probable MRSA. Okay, so remember, this is what you need to understand about surrogate marker for methicillin resistance and the reporting with respect to MRSA. There's one more question they usually ask. Okay. So this is the question that I think so most of your doubts will be answered compared previously. So I asked you, right? There is something called a susceptibility index. This is where we'll answer that question. So this report, you have a BAL, you have a growth of Pseudomonas aeruginosa. So based on your MICs, etc., since it is a pan-sensitive report, which will be the best drug here? Okay, so what we do something called as a MIC quotient or susceptibility index. Okay, so the quotient is clinical breakpoint divided by the patient's MIC. Okay, so what do we call this as? It will give you the headroom or safety margin for that bacteria to become resistant. Okay, so how am I going to explain it here? Okay, if this is a pictorial depiction for you guys to understand. Okay, for example, here amikacin has an MIC range here for that particular isolate being 1 and susceptibility is 16. So there is, you can see this headroom here which is so high, right? Okay, so if you divide 16 by 1, what is it going to be? 16. Okay, so again, if you take piptaz, okay, so it is 16 divided by 8, it will become 2. Which will be a better choice here? So all of this is susceptible only, right? You have ceftazidime which is susceptible, ciplox which is susceptible, levoflox which is susceptible, piptaz also susceptible. Okay, anything less than 16 should give it 16, or here you have 1. Okay, so you have to divide it by that particular number. Okay, so higher the quotient, it is better. Okay, for example, is it clear or you guys want me to answer it again? Okay, since there's no answer, basically susceptibility index is breakpoint divided by MIC. Okay, so if you're taking breakpoint divided by MIC, this divided by this. Okay, so this breakpoint will be common because it is for that particular antibiotic, and this is from the patient, that is the isolate. Okay, this number that is your susceptibility index is going to be different for different antibiotics. The one with the highest quotient is the one which is going to be taken as the safest choice. Okay, so usually a higher quotient will be the better drug because this is the drug which will have less chance to develop resistance. Okay, it is dangerous, and that is one thing which can cause development of resistance more faster. Okay, here again there will be a very tight fight, right? There is quotient 4 for amikacin, ceftazidime, and meropenem. So in this case, again, what would you do? So depending on where the site of infection is, you will go ahead and take that particular choice. Okay, if the patient is definitely in septic shock, probably you'll choose meropenem or carbapenem. Okay, if it is not, then you'll think about de-escalating later on. Okay, is it clear or it's still confusing for you guys? Did you guys understand this?
Yes, sir.
Okay, so if you're taking, for example, here, let us take Ciplox and amikacin. Okay, so for easier understanding here, okay, for ciprofloxacin, it's only one dilution away from developing resistance. Okay, but if you have amikacin, there is two dilutions which has to be done to come and gain the resistance. So that's the reason probably amikacin is a better drug of choice as compared to ciprofloxacin. Okay, so whenever we loosely tell this is a stronger antibiotic over the other, probably the best way to objectively tell a strong antibiotic is by using this method of susceptibility testing or MIC quotient. Okay. So for this, if you're taking 16 divided by 1, if you're taking this, it should be 16 divided by 8. Okay. Again, here it will become 16 divided by 8. Okay. So similarly, so it is the breakpoint divided by the MIC that will give you the quotient. Remember, higher the quotient, that is the safest choice. Okay. So if you can't remember anything else, higher quotient, better is the drug of choice for pan sensitive or multiple susceptible or sensitive drug. Okay. That's how you choose your antibiotic. Okay.
Sir, in
So
amongst
coming to
those,
this slide.
yes, sir. Sir,
Yeah.
amongst those antibiotics with the ratio 4,
Mhm.
there are 3 antibiotics, right? With the ratio 4.
Mhm.
So
Yes.
amongst them,
Yes.
which one would you choose?
Again, see, if you're seeing the quotient number is 4, but again, if you see here, the number of dilutions which is required to reach that 4 will be different. So if you see meropenem, 2 divided by 0.5, at least 3 dilutions there. Okay. And if you take Ciplox and amicus, okay, for example, we'll take the other one being ceftazidime. So 2, 4, and 8 probably. Okay, that will be 3 dilutions. So ceftazidime might be a little better choice in that. Okay, here both meropenem and ceftazidime would have a equal fight. So for this, for us to come to an understanding, we need to have this chart. Okay, so usually we cannot take this answer by ourselves. You need to call the microbiologist and ask them to calculate this for you, and then discuss with them. Okay, so this is the way that the microbiologist is going to tell you that this is a better choice than that, because this dilutions they will know. This quotient calculation also they can do it. Okay, it's not straightforward. So why you can't do is because you will only get your MIC and you will get your breakpoint. Okay, you will not get the cutoff for that breakpoint. Correct? That breakpoint will be given by CLSI or UCAST for that particular organism. So this is something the microbiologist will have. So you need to contact them and then you'll get that dilution. Okay, basically you need to have this chart with you. Okay, without this chart you will not be able to understand which is better. Okay, so for easier understanding, you see here, if it is 1 and then it is 16, there is a lot of dilutions which is necessary for it to come to a resistant state. Correct? This long headway is there as compared to tryptase. Okay, so this is what is the basic understanding. I'm sorry, this is not the same chart as compared to before. Why I put this here is for your visual understanding as to how they do a susceptibility quotient. Okay, so don't see these numbers here and then these numbers here. Okay, is it still confusing? I'm sorry, you can ask it again. I'm happy to answer it.
Sir, regarding the you are saying about the dilution part. See,
Mhm.
if we see the previous slide, sir.
Okay.
Yeah. So if we see for the breakpoint 2, from 2 to 1 and then 1 to 0.5, that means there are
Mm.
2 cycles, right, of
Mm.
doubling dilution.
Correct.
Same will be the case for ceftazidime as well. From 8
Correct.
to 4, 4 to 2, there are 2 cycles, right?
Correct. Correct.
And for
So
amikacin also 16 to 8, 8 to 4. So if we see that way, then all of them are equally efficacious.
efficacious. Correct. So this is this at whenever you have something similar, like here, whenever you have three things coming to the same level, at that particular time, you have to look at what is the site of infection, okay, and what is the clinical status, okay, and that is one you can choose that antibiotic, okay. So it's not one thing alone. So there is possibility that you will get the same quotient for multiple antibiotics as well. That's a very good question. This is what has happened in this slide. Okay. So whenever you have this, at that particular time, you'll take a broader spectrum of antibiotic as compared to a narrower spectrum. Okay. So that is what I told you. It depends on the site of infection and the clinical parameters of that patient. Okay. All of this matters. Your PKPD principles, all of that come. So first we need to start with this and then go to that. Understood? I'm still confused.
Yes, sir. Sir, confused. Yes, sir. Clear.
Clear. Okay. So see that this is all possible. See, for example, in this also you can have multiple MICs for that particular thing. It's basic mathematics, right? So it is going to be 4 by 4 is also going to be 1. Okay. And then 2 by 2 also is going to be 1 only. So that is what is happening here, if you can see here. Okay. You're understanding that concept, right? So whenever we talk about this, earlier only I told you, one, we need to look at the dosage. The second one is clinical stability, and then the spectrum of activity. So based on that, you can come to a conclusion, which is the better drug of choice. Start with your susceptibility index, then go look into all of this, and then you can choose. Okay, instead of blindly choosing. But what we usually do in bedside is we will look at the clinical stability and directly jump into consideration that this is the thing. Okay, probably few PKPD principles can be missed. Okay, so you might have heard that we need to call the microbiologist and ask what is the better drug of choice, why this is not acting, okay, etc. So these are the things they will look into consideration, and then they'll tell you which is the better drug of choice. Okay. So in this case, a 43-year-old male suspected meningitis comes to you, okay, and he was started on empirical ceftriaxone. Okay, after 48 hours, the culture revealed listeria, okay, which is sensitive to ampicillin, gentamicin, cipraloxin, cotrimoxazole. What would you do? Would you want to change or you want to continue?
We'll switch over to ampicillin.
Why?
Sir, for listeria, the drug of choice is ampicillin.
Why is it?
I don't know the reason as such.
Mm. Okay. Good. You know that there is standard choices when they're given. So whenever we're given all these standard choices of antibiotics, right? For endocarditis, we have a preset. For meningitis, we have a preset. Everything is there. No, it's based on the commonest organisms they pick up. Listeria is not one of the commonest organisms we see in meningitis, but here the problem is of intrinsic resistance, like one of you guys earlier mentioned, right? So Listeria is actually intrinsically resistant to cephalosporins. So that is the reason ampicillin becomes a drug of choice. Okay. And usually why we do a combo of Genta and ampicillin is basically to reduce resistance. And this is also based on the recommendation which is given for broader coverage. Okay. So usually what happens, we cannot practically remember antibiotics and the drug intrinsic resistance for all the organisms. So a good report will usually tell this. Okay, in the bottom it will mention it as probably it is intrinsically resistant to cephalosporins. So might have to consider this. Okay, so usually they will give it, but by and large it would not be mentioned. So whenever you have this, better to go check this. So that is one of the reasons, like you told, the drug of choice is ampicillin. That's because it is intrinsically resistant to third generation cephalosporins. Okay. So, summarizing how to read a culture report, first look at the organism name, from where it is taken, okay, the list of antibiotics, okay, check for any this thing resistance patterns, if at all you can look when you're looking at the antimicrobial result, okay, and then you look at your breakpoints based on your MIC, and then you can look at the clinical status of the patient and the susceptibility index to come to an understanding of starting which particular antibiotic. Okay, so this is how guys have to usually look at an antimicrobial susceptibility report. Okay, so usually choosing an antibiotic starts from the site of infection, looking for all the other issues, probably if the patient is having CKD, liver issues, etc., which can worsen toxicity, allergies, and then AST pattern. Okay, so this is basically how you go about. Okay, so there are a few examples that I want you guys to answer later on, but Ambler's classification for your drug resistance is something they will ask you whenever they are giving you culture sensitivity report. Okay, so there are 4 classes. How otherwise how are they categorized as? Beta lactamases. What are the types of resistance which is present in your?
Metallo.
What are the types of resistance? Okay, first question is what are the types of resistance?
Intrinsic and acquired resistance.
Good. Okay. Apart from that, what are the types of acquired resistance? What are the basic resistance patterns?
Foreign channels, efflux pumps,
Good. Good.
uh,
Foreign
carbon
Target site modifications. Okay.
modification.
So all of these are there. You please read up. Okay. We have already covered this in theory. It's going to be practically impossible for us to go back, but definitely please read to this. And when you're having amylose class A, class B, class C, and class D, they're again classified broadly into two categories, right? Based on their proteases. So what are they?
Metalloprotease and serine.
Excellent. So which are the metalloproteases? Which group?
Class B.
Class B. Okay.
Yes, sir.
So other three are serine proteases. Okay. So this is what I want you guys to understand. So amylase A usually consists of penicillinases like your 10, SHV, and CTXM, along with your other enzymes like KPC. Okay. So amylase B has your NDM, which usually is the commonest thing that we are seeing, along with IMP and VIM, which are growing right now. Amylase class C has AMC group of organisms, and OXA or oxacillinases are present mostly in amylase class D. Okay, so usually you need to remember this table. They'll just ask you questions based on this. Majorly, this is what they'll ask you, and they'll ask you what is the metal in the metalloprotease. What is the metal? I think so. You guys know that, right? Which metal is there in metalloprotease? That's it. Okay. Okay. So, how will you treat this patient? 67-year-old. This is the report they will give it to you in the exam. How will you treat? 67-year-old diabetic hypertensive female with recurrent UTI and acute kidney injury. What is your drug of choice right now?
Sir, we would like to know the breakpoint.
Your MIC is already given and the susceptibility is also mentioned right now. Okay. So here your susceptibility is only to what drugs here? What type of organism is this?
Sir, this is a CRE, carbapenem resistant Klebsiella.
Okay, so good. Okay, I have actually blocked the thing down below. It will give you a few answers.
Sir, actually, we would like to go for the synergy of ceftazidime, avibactam, and astronam.
Okay, so you want to ask for ceftazidime, avibactam, astronam, and then you want to check all of this. So there is susceptibility to tigecycline that I'm seeing. Then there is susceptibility to amikacin I'm seeing, and there is intermediate to colistin with an MIC of 1. You guys want to continue or choose anything before this? What would you wait? I mean, synergy will take time. Your Carbar essay, expert Carbar, synergy will at least take a few hours.
Sir,
The
what
best
about
center.
the phosphomycin?
Phosphomycin. It's not mentioned here. So I'm going to focus on something which is already here. Okay. So this is something that you need to pick up and answer. Why can we give tigecycline to this patient?
No.
No,
Urinary
sir.
penetration.
Why?
Urinary
Urinary
clearance.
penetration is very low.
Excellent. That is the point I wanted you guys to learn from the slide. Okay. You cannot use tigecycline. So until you wait for those tests that you guys asked for, okay, and in the meanwhile, what would you guys start for this carbapenem resistant Enterobacteria C?
We can
Cholesterol.
start on ceftazidime.
Carbapenem
We want
plus
to
cholesterol.
Based on the
see.
available
Please
report,
tell what you guys
we
are
have
doing
to
at the
provide with the
bedside.
colistin.
Okay, you want to start colistin and alone?
No, carbapenem with cholesterol.
Okay, you want to start with carbapenem and the colistin. Okay, so here you have amikacin. Why you still don't want to choose it?
Sir, because of the AK and nephrotoxicity of amikacin.
Excellent. Okay, so these are the things that I was looking at. Okay, so basically, firstly, from whatever antibiotic panel you have given, you have to choose the best possible antibiotic and substantiate why you cannot use the others. First, I have to identify that it is a carbapenem resistant Enterobacteria C. Okay, then you need to tell it is an MDR sepsis and what are the susceptibility panels. And in these groups, I would not choose tigecycline because it is ineffective in urinary sepsis. Okay. And my only choice as of now, while I'm waiting for a carbar assay, is to start him on a colistin based therapy, because colistin has a better drug activity in UTI. Okay. So this is basically how I wanted you to answer. It is a significant bacteriuria for someone who is asking the colony forming unit. Okay. So whenever you have had that, excellent. You guys asked CFU. That is one way to know it. Okay. But whenever you have a Klebsiella, which is MDR, please don't ignore it. Okay. It is definitely going to be a significant pathogen. You cannot just wait for a CFU there. Okay. So you ask for CFU when you're suspecting a colonizer. Okay. Especially with a patient like a immunocompromised patient, like an uncontrolled diabetic with recurrent UTI, don't think about a colonizer. Okay. You'll definitely treat this bug. Okay. So don't ask questions which will actually put you in a lot of other unnecessary questions. Okay. So be very straightforward and answer to the point. You guys were good in answering the things, but you need to taper it down and focus a little more. Okay. So next question is a 70-year-old patient in septic shock due to LRTI. This is the blood culture. Okay. So what would you do? You have everything. Okay. Time to positivity, everything is given. There are two sets. I'm just giving the second set. Okay. No need to worry about your CLAPSI, all those things.
And is having
So what is this?
take infection with shock with the organism is a Klebsiella, which is sensitive to only gentamicin and TG-cycline. As TG-cycline have as TG-cycline is resistant, intrinsic resistance, or it is cleavage by which enzyme. But basically, TG-cycline will not work for the low respiratory infection. So we will go ahead with the gentamicin.
So the thing is, tetracycline is ineffective in bloodstream infections and urinary infections. So,
higher doses, 100 mg treatment.
Okay. So what is the antibiotic of choice? You guys are not going. I mean, you need to be very focused when you're answering this question. You need to first tell it is a MDR CRO.
It's a CRE organism causing the septic shock with LRTI.
Very good.
So
this is septicemia.
Before we get the as well as with septic shock. So before we get the carbar report, we can go with an we can go with the local antibiogram starting with the carbapenem.
Okay.
Along with macrolide for LRTI.
Okay. So your choices here are a little very less, right?
Sir, since the patient is in septic shock, for the patient, I would like to go on a ceftazidime, avibactam, and astronam combination pending the synergy report.
Excellent. Okay. So when you have something like this, you can still start the patient on ceftazidime avibactam. Okay. You have that antibiotic right now. Patient is very septic and very bad. Okay. He has a multi-organ issue right now. Okay. So instead of trying a combination like this, better to start and ask for carbar assay. And after that, you can think about readjusting. Okay. So definitely the answer I was looking at is one of you told clearly, you have to start this patient, start it. Okay. And then if the synergy comes negative, then you can change it. But luckily, the synergy here was positive. Okay. So usually when you're looking at carbar assay and CRO, if the patient has NDM positive, what is the drug of the treatment protocol?
Astronam will be added.
Will be added. Okay. So if oxa and NDM, definitely you can give. If only oxa is present,
only ceftazidime avibactam
is enough. Correct. Okay. So that is the whole take home from these slides. Okay. Good enough. So they'll ask you very straightforward questions like this. Okay. So you need to understand the type of patient, the clinical context of the patient, the source of sepsis. Okay. Here I've I've tried to delineate telling it as LRTI, but the culture I've given you is a blood culture. Okay. So you need to remember it is septicemia. Okay. In this case, waiting and then treating would be a little detrimental. So you need to act quick. Okay. So I wouldn't tell directly that it is going to work, but then you can still start this patient on Zavicefta with Astronam and then de-escalate or change your management based on your reports. Okay.
And
So
sir,
you have another, yeah.
sir, regarding the previous one, prior to this, yeah. So therein cholesterol was intermediate. So with the patient with AKI,
Here,
uh,
is resistant, if you
no
can
sir, the
see.
previous one.
This one is it?
Yeah, yeah.
In the
So
UV process. Okay.
cholesterol is intermediate. So with the AKI, will we be worried about the nephrotoxicity of cholesterol as well?
Definitely, yes. We will be worried about the resistance. Okay. But then you have, that's why we are giving a combination therapy in this case, and we should pray that it works. In the meanwhile, you're waiting for your other drugs. See, colistin therapy is not the drug of choice for this patient yet, but you can still have a drug which can help you treat him till you get your carbapenem, your carbar assay. Okay. So definitely, if the carbar assay comes, like only OXA 48, then only ceftazidime avibactam can be given to this patient. Or if synergy is present for any other thing, then you can continue with that. You're waiting here, but here at least you have an intermediate possibility of colistin which is present. Okay, based on your culture sensitivity report. Okay, in this case, if you see, it is completely mentioned as resistant. Okay, to start this would be counterproductive. Probably you're going to waste some more time in this patient. Okay, so that is the reason. If you have an intermediate possibility, you can start this. Rightly you pointed out there is issue with nephrotoxicity. We would not be giving the full dose of colistin, but definitely you can give the loading dose. You can start with the creat clearance based dosing, correct? So you can anyways give a drug which is there and as a combination therapy in this case. Okay, in the meanwhile you can wait it out. There are few centers. If this patient was in shock, definitely I would have started this patient on ceftazidime avibactam aztreonam, because three things I'm worried about. Recurrent UTI, probably you have to reassess this patient. Why recurrent UTI? Is there an obstructive uropathy or a complicated UTI in this case? AKI, again, I'm worried. I don't want this patient to end up on RRT. Okay. In such cases, to prevent those things, I would start with a better drug like ceftazidime avibactam because it is a carbapenem resistant organism. Okay, so this is what I want you guys to understand. When you're answering, there will not be one single straight correct answer. You need to answer based on the clinical context, pathogen, and site. Okay, so this is what is the point of AST culture reports. Okay, am I clear?
Yes, sir.
Okay. Okay, this one. So you have a sputum report of Klebsiella. Okay, this is directly I put a carbar assay susceptibility report. Okay, so what do you see here? Can anyone read it out for me? This is an expert carbar. Okay, so this is what we have. So,
NDM, KPC positive and resistant to both ceftazidime, avibactam, and aztreonam.
there is resistant to ceftazidime avibactam also. There is susceptibility resistant to zavicefta. Both aztreonam also is not there. Ceftazidime was also not there. But then synergy became positive. So can I treat this patient with the combination? Yes, no. That is the understanding you guys have, no?
Yes.
Can I give zavicefta aztreonam to this patient?
Sir, depends on the clinical scenario. We need to rule out if it is tracheobronchitis, then it may not need treatment.
Okay, no, this is a significant pathogen. This is a significant pathogen. So good.
Then
I'm
yes, we
happy.
can treat.
Yes, we
Yeah.
can treat with NDM positive.
Okay, but why is it coming as resistant to ceftazidime avibactam and aztreonam? It should have been sensitive, no? So why does it come resistant? My question now is, why is this report coming as resistant? See here they've written ceftazidime avibactam MIC is 32, which is resistant.
Because of KPC?
Yes. You guys have to read the finer prints there. It is clearly mentioned. There's an external comment there. Can you read it? Okay, so whenever we are talking about Astronom resistant, usually you should remember Astronom is naturally immune to MBLs like NDM. Okay, but KPC can break it. Okay, so here you have KPC which is positive, right? So that was breaking the Astronom. Okay, Astronom is strong against your amylase class B like your NDM, but unfortunately, class A enzymes like your KPC can break it. So because it was breaking it individually, when you checked for Astronom, it will come as resistant. Okay. Similarly, when they took ceftazidime avibactam individually and they checked for it, your NDM was breaking it. That is your amylase class B was breaking it. Okay. So that is the reason when they are taken individually and susceptibility was tested, they come as resistant. But as a combination, they have a synergistic effect and they nullify each other. And that is the reason they become susceptible. And that is the reason they become effective in the patient. Okay. So now you understood? Is it clear?
Yes, sir.
Okay. Okay. One of you answer this question. This is the culture report that you have. What is the organism? It's grown in blood. Please answer. Guys, I have to give Dr. Niharika her chance also. Ma'am is waiting. Okay. There's ABG also waiting and there's drugs. So I have only an hour left for my drugs if you guys don't clear quickly. I
So
have few
this is
more
a
examples.
blood culture sample growing Enterobacter species. Yeah, it's a
લગભગ મળી જશે તમને.
fairly susceptible organism. The
જો
antibiotic response is
આપણે weakness અને તાવ
Azobactam.
I'm sorry, there's a lot of background noise. Okay, you told it's a blood culture organism. There is susceptibility to a lot of antibiotics here. Okay, so what is this organism which is grown?
Enterobacter species.
Enterobacter. Okay.
Gram negative.
Gram negative. Okay. Enterobacter comes under what class of species or resistance mechanisms when you're talking about? What are we worried about this pathogen? What is the drug usually used for Enterobacter? Then what are we worried whenever you're seeing it in blood? Enterobacter bacteremia. So what is your drug of choice? Let's forget all of this.
In this, I would like to go ahead with piperacillin tazobactam.
Piperacillin tazobactam. Okay. So why not choosing cefepime, ceftriaxone?
Ceftriaxone because the another third generation of antibiotic that is cefuroxime is resistant to it, so there may be resistance, in vivo resistance to ceftriaxone as well.
Okay, but that's unlikely. No, ceftriaxone is a third generation cephalosporin.
Yeah.
Okay. Anyone else wants to answer this? Who wants to go with meropenem? Okay. So Enterobacter falls under which group? Anything you guys want to change now after looking at this? It falls under the escape group of organisms, which has higher chances of giving what? AMP-C induction, correct? So whenever these patients are getting any cephalosporins, especially first three group of cephalosporins, usually even if they say it is sensitive, the failure rates are very high because they develop resistance during treatment. Okay, so that is one of the reasons we say don't use cephalosporins for these group of patients. Okay, so usually what happens is the next important thing is I told you what was the first question I asked you. It is Enterobacter bacteremia. So whenever you have bacteremia present for a AMC organism, that is your escape or your space group of organisms, better to choose a carbapenem like meropenem. Okay, because it's a bacteremia. If it is a very localized type of a sepsis like a UTI, probably you can think of using the Piperacillin tazobactam. Okay, because here the
राकेश भाई
stability.
ओ राकेश भाई जीप बताओ
Hello.
लो बोल
हाथ ऊंचो करो
Hello.
આ જીપ અંદર મૂકી દો
Bhagesh, I think so. We need to mute. Okay, this is a lot of.
હાથ ઉપર કરો તમે બોલી નહીં શકો તમે બોલવાનું ટ્રાય ના કરતા તમે જ્યારે બી ટચ કરો ને ત્યારે પહેલા પણ હેન્ડ વોશ કરી લેજો હાથ
I think so. We need to unmute the person, Bhageshri, whoever it is. I'm sorry, guys. So I was telling you earlier. Okay, so whenever you have AMP-C in blood, the drug of choice would be carbapenems. Any localized site of infection, probably you can use a BLBLI. Okay, so that is the take home from this slide. Okay, so you'll get
So
Enterobacter.
can we start cefepime for this patient? It's the first line.
Okay, so okay, good. So why can't we start cefepime in this? Cefepime is which group of cephalosporins?
Fourth generation.
Yeah, so it's still plus minus in this group. Okay, so when you're having this, if it is clinically stable, okay, that is without shock, you can still think of using it. Okay, because there's still susceptibility which is present and stability is also going to be there. But if there is hemodynamic instability in this patient, based on the clinical parameters, the drug of choice would be carbapenems. So cefepime is still a possible choice. Okay, but the first 3 generations of cephalosporins is a strict no. Okay, so if you see this table, you'll understand. Okay, so Enterobacter bacteremia, cefepime, if stable, you can use carbapenem if severe or high risk. Okay, I think so I've answered your question. Okay. Okay. So why cefepime can be used is because of this. Okay, it has something called as a Zwitter-ion structure. Okay, so since it's a 4th generation cephalosporin, okay, so it does not allow this rapid pore penetration. Okay, so it will cause lysis of this bacterial cell. Okay, because the periplasmic concentration of cefepime will be higher. Okay, so this is the reason, even though this AMC is produced, this enzyme will be overwhelmed because of this porin production and penetration of this cefepime into the periplasmic space. Okay, so this is one point I want you to take in. Okay, so this is one question they will definitely ask you. Okay, so cefepime definitely can be used, but depends on clinical stability. Okay, I'm clear till now, right? Any doubts? Okay. Next question. So I probably will wind up after this and then go with drugs, okay? Because I'll have hardly 1 hour to complete drugs. If you guys answer quickly, we can answer a few more. Okay. I have a few more. So this is urinary E. coli. What do you guys want to do with this? How is ESBL screening done?
If resistant to third generation cephalosporin, we can consider them as ESP.
Okay. So is it screening or it is confirmatory? So you should check clavulanic acid. Okay. If the screening comes positive and clavulanic acid is able to reverse it, then you will tell ESBL is confirmed. Okay. So this is how you do it. It's a stepwise process. Okay. So clavulanate usually helps remove this resistance induced by ESBL. ESBLs is what Ambler's classification?
Class A.
Class A. Very good. Can whoever answer that, you know what are the sub enzymes in ESBL? Like MDM we have for class B, right?
CTXM.
Very,
CTXM.
very good, very good. Okay. CTXM is the most commonest type of ESBL. Okay, there is CTXM, SHB, and TEM, I think so, if I'm not wrong. Okay. So usually, what is the drug of choice for ESBL? Answer is there. Please read it.
Carbapenem.
So can we use BLBLI like Piptas? The answer is still there. What does your Merino trial tell? It was on BLBLIs versus carbapenems in ESBL organisms. In which source? Urine, blood, sputum.
ત્યારે બોલવાની ટ્રાય કરશે અને બોલી નહીં શકે અને બોલવાની ટ્રાય કરશે એટલે ખાંસી આવે. ઇનફેક્ટ આપણે એમને પરેશાન કરી રહ્યા છીએ એવું થાય.
I really want one of you guys to please, whoever's speaking, please unmute yourself. You're disturbing a lot of other people. Please mute. Bhageshji, please look at.
સાંભળતા નહીં તો એમ જ કમાન્ડ.
Carbapenems are better than BLBLI in Merino trial.
Okay, so in Merino trial, where was this looked into? Which was the source?
Blood was the source.
Very
Bloodstream
good.
infection.
Bloodstream infections. Okay, so piptas, was it an inferior to non-inferiority trial, or what did they look at?
Non-inferiority trial.
So what was the result? Can anyone tell me what was the result? Because it's a very favorite question of examiners. The result
There
was
higher
mortality with
fertility.
piptas.
It was
Piptas was
terminated early because of the high mortality in piptas group.
Okay, so but the result they wrote it as piptas was non-inferior to meropenem. That's what they wrote it. So the understanding of this is actually meropenem is the drug of choice for ESBL bacteremia. Okay, so can we use piptas at all in any of the other ESBLs?
In urinary ESBLs, it can be used.
Okay, urinary ESBLs it can be used. Okay, so it's not very straightforward like that. Okay, that's the reason why I asked others what are the enzymes was this reason. Okay, CTXM whenever it is present, right, you cannot use it. Okay, so the effectiveness of piptas is very minimal with them. Okay, so only when it is Temonara or SHV, we plus or minus. Okay, so whenever we have these two, we need to look at whether it is blood or urine. So if it is urine at that particular time, yes, it may act. But again, clinical status matters. If it's urine and shock is also present, probably the drug of choice will be carbapenem. Okay, so that is the take home I want you to have. So if at all there is carbapenem resistance which is seen, then your ceftazidime avibactam is the drug of choice for or alternate for ESBL organisms. Okay, is it clear? See, please know your AMCs, ESBLs, NDM, OXA48. Okay, so these are the straightforward questions along with your MRSA and VRE. MRSA and VRE, it's really quite old for us. We are not repeating it, but I'll just touch upon them. Okay, so what is this culture report? It's a urinary enterococcus, correct? And the colony forming unit is 3000 and probably it's significant. So what are the key species? How will you treat this patient? Is there a difference? Do I have to worry? What type of organism is enterococcus?
Gram positive.
Thank you. Okay. So where all do you see this? Apart from this, which other group of privileged site infection do you see?
Abdominal infections,
Endocarditis.
urinary infection, endocarditis.
Okay, when I talk about privileged, these are very high risk areas. Okay, so it's usually going to be meningitis or endocarditis, or else probably a prosthesis wherever it is present. Okay, these are privileged sites. Okay, so you just listen to what the type of questioning is. Okay, so good, you guys told it, it's endocarditis. Okay, so remember, these species have an intrinsic resistance to cephalosporins, and use of aminoglycoside as a monotherapy is not going to be efficacious. That's why most of the endocarditis treatment is always a combination therapy. Okay, because usually this is insufficient blood levels to get complete removal of the bacteria from the site of infection. Okay, so whenever you have fecalis or faecium, depending on what is the type of sepsis, whether it is UTI, bacteremia, endocarditis, you have choice or combination therapy. Okay, so you need to know this. Okay, for fecalis and faecium, what is it, and for that type of site of infection also you need to know. For uncomplicated UTI, it's ampicillin or amoxicillin. Okay, so if it is enterococcus faecium, you have nitrofurantoin or phosphomycin can also be used. If it is no endocarditis, you can use plain ampicillin, but if there is endocarditis, it should be a combination therapy. Okay, VRE, you guys know it's either linezolid or daptomycin. Okay, ICU, it should usually be a combination therapy. Okay, so usually you need to check for aminoglycoside resistance also. There is something called as high level aminoglycoside resistant check. So sometimes you'll be treating, but day 3, if you're still not having some return of normal parameters, probably you have to check for this. What you assume is an aminoglycoside is working, and if the patient has developed a HLR, probably this is not a good antimicrobial therapy. These patients require antibiotics for a longer time, right? So to assume that it is taking time for approval is wrong. Okay, so day 3, day 5, if you see that this is not improving, better to get this checked. Okay, so you need to know VRE management in total whenever you get this culture sensitivity report. Okay, so coming to the last one, it's about colonizers. Okay, so cons is one thing, like you guys earlier told. Okay, look for a colonizer. Colony forming units are something that we need to look at. Clinical status becomes very important. Okay, so whenever we're thinking of colonizers, look whether there is where the infection is, the site. Okay, then the colony forming unit and temporal context. What do I mean by temporal context is this is if the patient develops sepsis, fever, shock, okay, and then you have done a culture, and then some organism has grown, probably this is not a colonizer and it is a pathogen. That is what we mean by temporal context. That is, you did a culture because there was a change in baseline parameters. Okay, so at that time you need to think twice before concluding that this is a colonizer. Okay, this is all what that matters. Okay, so remember, whenever there is a pathogen in blood in immunocompromised patient, more likely that colonizer is not a colonizer, and it mostly is a pathogen. Okay, so along with this, you need to know there are few organisms. If it's a BAL, if the pathogen threshold is more than 10 to the power 4 colony forming units, it's definitely a pathogen. If it's a protective brush specimen, probably 10 to the power 3. Okay, if it's an endotracheal aspirate, heavy growth is what they'll usually mention. If heavy growth, it's definitely a pathogen. Okay, so remember, neutropenic patients, post-transplant patient, colonizers may be the pathogen. Okay, so you definitely have to treat them. Okay, so always presence is not infection. Look at the burden and the inflammatory state causing mods. Okay, that is one thing that you need to have in mind. Okay, so if you want to take an overall perspective of what is the cutoffs for CFUs for each sample, that is your respiratory, urinary, and blood, this is the slide I want you to take in. Okay, it will take some time. Definitely don't directly interpret it as these numbers. They are not strict and straightforward. Okay, it depends on the clinical context as well and the hemodynamic stability of that patient. Okay, so in summary, if there is a low colony forming unit, there is no clinical syndrome, don't treat. Okay, but there is clinical syndrome present with low colony forming unit, probably observe and repeat the culture. If there is high colony forming unit, but there is no clinical syndrome, look for alternate site. Probably you're looking at the wrong culture report. Okay, probably there is some other issue. You need to look for alternate source of sepsis. If there's a high colony forming unit and a clinical syndrome, definitely treat it. Okay, so this is how you take an understanding about colonizer versus pathogen when they give you a culture sensitivity report. Majorly, they will give you cons only, and then they will ask you to answer. So look, remember first question, site, colony forming unit, competent patient, compromised patient. Okay, then the whole picture, that is your shock, hemodynamic stability, etc. Okay, so this is about interpretation of AST. Okay, thank you. So I think so I've overshot. Okay, I was supposed to finish it at 5. Any doubts till now? So the last talk which I have to complete is drugs. Okay, so in this I think so I had to do antibiotics. So any questions till now? Any doubts till now? Is this slide visible?
Yeah, Darshan.
Okay. So how do you guys classify antibiotics? Guys, you need to unmute and answer. Bhagishri, are they allowed to answer no, or you muted all of them?
According to the site of action,
Okay, good.
whether they're cell wall synthesis inhibitors, whether they're protein synthesis, either 50S inhibitors or 30S inhibitors, or
Okay.
DNA gyrase inhibitors.
Okay, good.
Or second classification would be whether they are static or sidal.
Very good. Okay. So you have to remember all of this and remember a few examples of them. Okay. So clearly you mentioned cell wall synthesis inhibitors, protein synthesis inhibitors, nucleic acid synthesis inhibitors, metabolic inhibitors, and cell membrane disruptors. This is one way to tell them, or static and sidal. Okay. So if you have to give me examples for each of them, I think so it's mentioned here already about the class of antibiotic. If you want to give me an example for sidal versus static, can you give me two examples? Give me an example for sidal drug.
This carbapenems and cephalosporins are sidal drug, whereas static would be tetracyclines are static drug.
Very good. Okay. So now tetracyclines are what kind of antibiotics?
So they act on the protein synthesis inhibitor. They are
Very
the
good.
yes.
Okay. So
They act on the 30S
sir,
ribosomes.
okay. So you know that no at 30, correct? So they are protein synthesis inhibitors. So they are going to prevent protein synthesis. So aminoglycosides are bactericidal drugs or static drugs?
Sidal.
Sidal, no?
Yes.
So then how is it different? 30S usually has to be static drugs, no? Why is it sidal? See, both are acting on the same site, correct? That is your 30S ribosome. But why is one static whereas the other is sidal?
I don't know.
Okay, so usually what happens, no? Aminoglycoside, the binding is irreversible to the 30S subunit, and it causes something called as misreading of the RNA. Okay, so because it causes irreversible attachment to 30S and uh, missense reading of the RNA, it produces something like a defective protein. Okay, so because it produces this defective protein, there is increased chances of cell wall breakdown or poor protein buildup, and then the bacteria gets lysed. But tetracycline, what happens when the drug is being present? It is going to be reversibly bound to 30S ribosome. So as long as tetracyclines are present, it will just arrest the bacteria. Okay. So as soon as the tetracycline is removed, the bacteria can regrow again. Okay. So that is one of the reasons that tetracyclines are static and aminoglycosides are sidal. Okay. Remember, irreversible binding and missense reading of the mRNA by aminoglycosides make it a sidal drug, even though it is acting on the 30th subunit. Okay. So can you give me examples of tetracyclines? It's written there. Aminocycline, tigecycline, doxycycline. Okay, all of them are tetracyclines. Okay. So coming to PKPD principles, you need to classify all your antibiotics based on PKPD principles as well. Okay. So majorly you need to tell what is time over MIC. What are the examples? I've given you the table also for answering. It's going to be easy.
Time over MIC is vancomycin.
Time over MIC.
Beta lactams.
Okay. Vancomycin is it time over MIC? So whoever said vancomycin, which group of antibiotic does vancomycin fall under?
Glycopeptides.
Glycopeptides. Excellent. So majorly they are active against what group of bacteria?
Gram positive, MRSA.
Okay, good. Okay. So this is what you need to understand about. So usually it falls under AUC by MIC. Okay. So your beta lactams are the ones which follow time over MIC. Your aminoglycosides follow the concentration dependent killing. Okay. So why is PKPD important for us?
Sir, it is a part of the antimicrobial stewardship program nowadays.
Very good.
Because so they're just giving the antibiotics without following appropriate dosing can increase the resistance pattern as well as produce ineffective results, that is reduced clearance of the infection. As a result of this, PKPD principles are important. Other thing is also monitoring the drug levels, toxicity. That also is another part.
Very good. Okay, good.
Also
So basically,
dosing of the drugs.
very good. Dosing. Okay. So how frequent you need to dose the drug, okay, and the effectiveness of the drug. All of this is based on the PKPD principles. Good enough. Okay. So if you know this much, and one of you told drug levels, etc., right? So next question is, what is post-antibiotic effect? See, it's
Seen
very
in
simple. Please pick up one antibiotic and tell, okay, but then they'll ask you questions like this when you pick up that antibiotic. Okay.
seen with aminoglycosides and quinolones post antibiotic effect.
Okay, why? What does it mean?
It basically means even if drug levels below the MIC, still there is a suppression of the bacterial growth.
Okay. Okay. So usually how does that happen is because I told you earlier, right? Static versus sidal, etc. Okay. Usually static drugs are something that we are worried about. Okay. But sidal drugs usually have a better outcome. Okay. So they have a longer post antibiotic effect. Okay. So this is what matters to us. What we want to know is even after we stop the antibiotic, is this patient going to recover completely or not? Okay. So usually we give antibiotics for 5 days, 7 days, etc. Right. So this is what we are dependent on, whether our particular antibiotic has a PAE or not. Especially depends on the type of antibiotic that we are looking at and the type of pathogen. Okay. So good, you guys told earlier, aminoglycosides usually have a PA duration of 2 to 8 hours, fluoroquinolones between 2 to 6 hours, carbapenems actually is not good. Okay. Macrolides and rifampicin have a longer one. Okay. Remember your beta lactam antibiotics, like your peptides, etc., are having the least amount of post antibiotic effect. Okay. So aminoglycoside is the classic example to talk about stronger PAE. Okay. So that is one of the reasons even once daily dosing can be given because the bacteria doesn't regrow immediately. Okay. Again, fluoroquinolones also is a good choice. Sometimes that's why we give it as a BD or OD dosing. Okay. And we can send the patients back home also with these drugs on oral therapy. Okay. Uh, beta lactams, you should remember it is one of the ones with lowest PA. Okay. So the next question they are going to ask whenever PKPD principles are questioned about is TDM. Okay. So TDM, I think so, is one of the questions that they asked you in your exams recently. So you guys have to answer them. So which are the commonest drugs which are included for TDM monitoring in the ICU? Most common? You guys had this question, right?
Vancomycin.
Vancomycin, good. Anything else?
Even voriconazole.
Voriconazole, good.
Um,
You're sticking only with antibiotics. That's the clue.
Anti-epileptics like phenytoin,
tacrolimus.
tacrolimus.
Yes, good. Tacrolimus. Okay, levetiracetam. Okay. So is it only for these cases where we use? Can you use it in any other setting in ICU?
Immunosuppressants.
Immunosuppressant, tacrolimus, you've already given. See, whenever someone comes with drug overdose, also you can send, no?
yes.
Yes.
So yeah, please think. Okay. So you have to categorize, classify your answering. Okay. When your question is there, please think about this. We can give multiple answers. Okay. So remember, TDM usually are used for drugs with narrow therapeutic window and higher interpatient variability. Okay. So in which group of patients do you see this higher interpatient variability? Patients with increased volume of distribution, like in sepsis, fluid overload, okay, capillary leak or third spacing, patients with augmented renal clearance, okay, patient on extracorporeal therapy like ECMO or CRRT, okay, patient with hypoalbuminemia and organ dysfunction. So all of these places are places where TDMs are required. How do we do it? When do we send the sample?
Probably send
Trough
the trough
levels to
levels
be
before giving the dose.
So which drug we send trough levels? Only trough levels are checked, or something else is checked?
No. Ideally, it should be at least 3 to 4 doses of adequate drug exposure, followed by level to be withdrawn 15 to 30 minutes before the fourth dose or sequent dose.
What are you checking there? Trough or what? See, please read up about this. This was your question in theory, okay? So trough levels are not the only things we look at. We look at something called as peak levels also, okay? So clearly you told one thing, that is about after 3 to 4 doses we do it, okay? That is one thing that is done, okay? But that is for one part only, that is for trough sampling. There's something called as peak sampling, okay? So for peak sampling, when we do is usually for gentamicin it will be 30 minutes after infusion, or amikacin it's usually going to be 30 minutes after infusion, okay? Both of them roughly, this is the one which we do, okay? So there is something other than this also which is there, that is called as area under the curve based sampling, okay? Usually vancomycin from trough levels, they are moving to this. Now there are automated Bayesian system analysis, or AI is also coming into picture, okay? So this is what is used for accurately checking the drug levels in the body, okay? So basically you need to know it's not just trough leveling which we do in TDM. We do something called as peak sampling and area under the curve sampling also, okay? So I'm not going to drill much, but if you can take a screenshot of this, what drug, what type of TDM method, see how many are there here. Trough base, peak and trough, AUC by base. You need not remember all of this. Remember one example for this, okay? Majorly what we are worried about is your anti-epileptic drugs, your immunosuppressant drugs, and in antibiotics, whenever we're talking about, usually we talk about your glycopeptide like vancomycin, okay? So if you can remember these, that was good enough. Or else if you just mention these names also, the examiner will understand that you have fair idea of what is happening. The reason I mentioned this here is because it was a theory question, the probability of them asking these questions are higher. Okay, so now let's go to individual drugs. So ceftazidime is the first drug. Who wants to go and answer about it? In the meanwhile, you guys can take a screenshot of this if you want to read back. So the next is only going to be drugs. Okay, for the next half an hour or so, it's only going to be drugs. You guys have to answer. Ceftazidime. So this is the drug which is kept in front of you. How would you answer?
So, ceftazidime is a cephalosporin class of drug. It belongs to the third generation of cephalosporin. Yeah. The mechanism of action is it acts on the cell wall synthesis. It's a cell wall inhibitor.
Very good.
Yeah. Dose usually is 2 gram IV Q8 hourly, but it has a creatinine clearance as well. It has a good gram negative coverage, antipseudomonal coverage, and has got good CNS penetration as well.
Okay, excellent.
Yeah, the side effect profile is it has got nausea, vomiting, diarrhea, along with that rash, which is present with beta lactams antibiotics, and rash and maybe thrombocytopenia and thrombocytopenia and these are the only adverse effects. Yeah.
So you just generalized. Whatever you told is generalized for most of the antibiotics. Rash probably is one of the rarer ones, but you can still tell that. Okay, but try and think about a few common things. Okay, like I mentioned last time when I was dealing with drugs, pick up few antibiotics, learn them properly. Okay, and know the salient points or salient adverse effects for that particular antibiotic. Okay, fairly you have done well. Okay, good. Coming to the next antibiotic, linezolid. Who wants to answer this? What is the group of antibiotic, linezolid?
Oxazolidinone.
Guys, good. Oxazolid. Okay, answer. Where do you use it? What is the dose?
So the dose is 600 mg IV or oral Q12H. The use is most commonly in skin and soft tissue infection. Along with that, even pulmonary infections, and basically for gram-positive coverage in MRSA and VRE.
Okay, good. It's used for MRSA, VRE. Okay, what is the dose?
600 mg Q12H IV or oral.
Okay, good. So where does it act? See, you're not supposed to make the examiner ask you multiple questions, okay? So you need to tell that clearly. You just told protein synthesis, you have to tell that, and adverse effects, you need to be clear, okay? So you start with the antibiotic class, dose, PKPD principle, mechanism of action, and adverse effects. Basically, at least if you don't tell in so many things, at least the class, dose, mechanism of action, and adverse effects. These four are mandatory for any antibiotic. Okay, so remember, it acts on the 50th ribosomal subunit. It's a protein synthesis inhibitor. Okay, excellent coverage for gram-positive bacteria, especially a Staph aureus and Enterococcus species. Okay, VRE is one place where you use this drug quite often. The adverse effects, the most important thing that we want you to know, linezolid, line. Okay, remember that way. It causes myelosuppression. Thrombocytopenia is one thing which is routinely seen with the use of linezolid. Okay, another common side effects which is seen with the use of linezolid, especially patients on antipsychotics, is serotonin syndrome. Okay, why does it come in that cover? You have seen the bottle, how it looks. What color bottle is it?
It's photosensitive.
Yeah, why? Why should it be placed in that cover? It's photosensitive, definitely. What happens with that reaction? What photosynthetic reaction changes here? This oxazolidine ring which is there, right? It is susceptible for UVA radiations, okay? So that will break down. So the drug itself will become ineffective. So that is the reason it comes in that cover, and that bottle is also brown in color, okay? So you need to know this. This is one of the favorite questions they'll ask you if they pick this up, okay? And if this cover is still there. This, I think so you guys can answer, right? MDR, CROs, you can use this. What is the dosing? How does it act? So it's a BLBLI, effective against gram-negative bacteria, including Enterobacteriaceae and Pseudomonas aeruginosa. Okay, 2.5 grams, 8th hourly is usually the standard drug. Usually it consists of 2 grams of ceftazidime and 500 milligrams or 0.5 grams of avibactam. Okay, so it causes cell wall synthesis inhibition, binding to the penicillin binding proteins. The avibactam which is present, it is a beta-lactamase inhibitor. Okay, so usually it is known to cause hypersensitivity reactions, transaminitis, and C. diff diarrhea. Okay, so coming to clindamycin is a, okay, anyone wants to answer clindamycin?
Clindamycin is a lincosamide class of antibiotic. It acts on the 50S ribosomal subunit. So the dose is usually 600 mg IV Q8H. The uses are it has a good skin and soft tissue coverage, along with that anaerobic coverage. It can be also used in the treatment of PCP pneumonia along with primaquine. And basically for skin and cellulitis, necrotizing fasciitis, it is a good choice of drug. The adverse reactions are, it can cause C. diff diarrhea, and that's what I know. C. diff diarrhea.
Okay, good. This one? Which group of antibiotic?
It's a cephalosporin class of drug belonging to the fifth generation of cephalosporin.
Fifth generation.
Yeah.
Very good.
Yeah. So it has got a good MRSA coverage, and the gram-negative coverage only is similar to the third generation cephalosporin, and in the third gen it does not have anti-pseudomonal coverage, ceftaroline.
Very good, very good. I wanted those 2 points especially. Okay, MRSA cover is there, anti-pseudomonal labs. Very good. This is what we are expecting. And you told this, but you forgot where it acts. Okay, remember, especially it acts on the PVP2A. Okay, this is the gene which causes the resistance pattern in MRSA. Okay, so along with your MEK gene, right? So this is also going to be present. Okay, so remember these things. Okay, so by and large, good, but you can still improve how you tell the answers. Okay, remember the dosing and all. Most of the times it will be there. Okay, you just have to pick it up and you can read it as well. Okay. So the important side effects, along with all the things that we have mentioned about C. diff, diarrhea, hypersensitivity, it is also known to cause myelosuppression. Okay, so this is something very rarely. It has also been reported that it has caused hemolytic anemias. Which group of antibiotic?
It is a newer tetracycline class antibiotics.
Okay.
It got anti-Acinetobacter coverage. Basically,
Very good.
acts against the Acinetobacter baumannii. And
Okay.
the dose, I'm unable to recall, sir, the dose.
No worry. Okay, but it's a tetracycline glue that you're told. Okay, for carbapenem resistant Enterobacteriaceae or Acinetobacter is a good thing. Okay, remember the dose is 1 mg per kg. Okay, usually it is given as a BD dose. Okay, so it again acts at the 30th ribosomal unit because it's a tetracycline. Okay, it is bacteriostatic, so it can never be used as a single agent. It should be used as a combination therapy. Okay, as of now, since widespread usage of this is not available, the side effect profile is still something that we don't know. Most commonly, you can tell about hypersensitivity reactions, anaphylaxis, C. diff, diarrhea, etc. Okay, so any higher group of antibiotics, C. diff, you can easily mention. It will definitely cause it. Okay, what group of antibiotic is Astronum?
It's a monobactam class of antibiotic.
Very
The
good.
usual dose is 2 gram IV 8 hourly,
Very
which has got a creatinine clearance. Other thing is the mechanism of action. It acts on the cell wall synthesis. It's a cell wall synthesis inhibitor, and
very good.
uh, adverse reactions are either rash, diarrhea. Yeah.
Very good. Okay, so you remember PBP3. Okay, so I told you about your fifth generation cephalosporin. It's PBP2A, like your MRSA, right? For Astronum, whenever you're talking about MDR CROs, usually it acts at PBP3. Okay, so if you can remember, you remember. Otherwise, it's okay. Okay, but PBP2A is usually what they ask about, and VRE whenever it is coming when. Any other thing when you're talking about glycopeptides per se, the sequence is DLNN, DLNN. Okay, that is one thing they'll ask for. How does it act? Okay, because even that is also involved in cell wall synthesis inhibitors. Okay, so this is one thing you need to remember when you're talking about vancomycin, that is your glycopeptide, and your other cell wall synthesis inhibitors, like we mentioned earlier. Where does sulbactam come into picture? Which group of antibiotic is this?
It's a beta lactamase inhibitor group of antibiotic. It is
Very
used
good.
in the along with a combination of beta lactam like cephalosporin, um, that is cephalosporin sulbactam, BLB-LI combination, or use isolated in the treatment of Acinetobacter baumannii as a second line therapy after polymyxin and minocycline. Then
Oh,
the site of action is it's a beta lactamase inhibitor. Then so basically the mechanism of action. Then the dosing is when it is combined along with a beta lactam, the usual like the dosing will be either 500 mg Q 12H or 1 gram Q 12H. But when it is given for the treatment of Acinetobacter, then it is either 2 gram IV Q8H with a creatinine clearance. The other adverse effects as it has got nephrotoxicity and rash and
okay.
liver enzyme elevation.
Elevation. Good. Okay. Usually it causes transaminitis. That is what we look at whenever we start a patient on high dose sulbactam therapy. Okay. So beautifully you mentioned whenever it is taken into cephalosporin sulbactam, that is a different dosing interval. But when you're talking about Acinetobacter species, up to 9 grams per day. Okay. Your 3 grams TID is what is allowed. Okay. So this is what we're looking at. Can you enumerate any other beta lactamase inhibitors? Name them. Just name them. There's a classification, but if you can name them, it's good enough.
So clavulanic acid, tazobactam, and the newer one, vaborbactam.
Very good. Oh,
Relebectam, Weberbectam.
very good. Okay, good. Okay. So they are all boronic acid derivatives like that. Okay. There are new imipenem, delibactam, darlobactam. Okay. So all of them are there. So one thing, if you have to answer about this, what would you tell? Where can it not be used?
It should not be used in pulmonary infections because it is inactivated by surfactant.
Okay. Where do you use this? For which group of organisms?
For VRE.
Very good. Okay. So what type of antibiotic is this? It's a lipopeptide. Okay. So majorly it's for MRSA and VRE. You have to remember the dose is depending on the site of infection. Okay, it's 4 to 6 milligrams per kg for skin and soft tissue, and 6 to 10 mg for bacteremia and endocarditis. Why it's very important is because this becomes very important when we have difficult to treat infections. Okay, so you need to remember the dose is different. Okay, so it is bactericidal but not effective in treating lung infections. Okay. So coming to antifungals, can anyone classify antifungals? It's there on the screen. See, you need to answer the classifications, okay? Don't think that it's only going to be antibacterials. Okay, I can ask one more question in that. So before that, you guys have to answer this antifungals. Guys, I have roughly 20 minutes to wrap up because I have to let madam start her class. So you guys have to answer. Okay, so usually antifungal classification is based on whether it is a cell wall synthesis inhibitor like your echinocandins, okay, or cell membrane integrity disruptors like you see in your antibacterials also. Like your amphotericin B is the one which is a cell membrane or cell membrane integrity disruptor. It causes some pores in the ergosterol layer, thereby delivering the antifungal and killing the fungus. Okay. And then there is nucleic acid synthesis inhibitor like flucytosine, ergosterol synthesis inhibitor, which actually blocks the 14 alpha demethylase. You just can remember it as ergosterol inhibitor. That is your major chunk. That is your azoles. Okay. Then you have lanosterol synthesis. That is your terbinafine. Mostly it is for topical applications. You remember your cell wall synthesis inhibitors because echinocandins fall there. Ergosterol synthesis inhibitors, you have to remember. Again, all your azoles come there. And your amphotericin B falls under polyenes, which is your cell membrane integrity disruptor. For fungal nucleic acid inhibition, you need to remember flucytosine. Okay. So anyone wants to answer this? What is this? And where is it used? Okay, what type of antifungal is this? Okay, it's a polyene antifungal which binds to ergosterol. I told you earlier, it causes pores in the fungal cell membrane and causes electrolyte leakage and cell death. Okay, so usually it is available in two forms. Okay, so your liposomal form and your colloid dispersion form. Okay, so usually invasive candidiasis, the drug dosing is different. Okay, so whenever it is lipid formulation, it is a different type. So it can range from 0.5 to 0.7 up to 1 milligrams per kg per day. Okay, or if it's an amphotericin which is liposomal, it is usually 3 to 5 milligrams per kg per day. Okay, so it can be used for aspergillosis, blastomycosis, mucormycosis, CNS fungal infections. Okay, so remember that is one thing. Okay, so why is it different? Why do we need to have this liposomal amphotericin B?
Because it is less nephrotoxic.
Very good. Why is it less nephrotoxic? So usually what happens, no? This amphotericin is also made up of lipids. Okay, so when it goes into the nephrons, it causes tubular damage because it gets stuck onto the tubular cell membranes. Okay, so wherever there is lipophilic activity which is present in the tubules, this amphotericin goes and binds there, and then it causes acute tubular necrosis. Okay, so to prevent that lipophilic attraction of amphotericin to the normal nephron there, they put another lipid layer around the amphotericin. Okay, so that is the reason it does not cause nephrotoxicity. So the next question would be there, if it is present as a vesicle, which is going to be delivered, how does it act? Correct. So that is going to be the next question. Liposomal means there is a liposome which has this active amphotericin B. So how does it act at this site? So usually it is by phagocytosis. Okay, whenever there is an infection, the drug would be delivered there. It causes a phagolysosome, and that breaks this. At that particular site, this drug would be delivered. Okay, so because of phagocytic activity, there will be breakdown of liposomal amphotericin into amphotericin B, and there will be delivery of the drug at the site of sepsis. Okay, so it will spare all the other areas. Okay, coming to azoles. Azoles, you know what is this? Ergosterol pathway, 14 alpha demethylase. Okay, so basically cell membrane disruption causing cell lysis and death. Okay, so it can be used for most of the fungal sepsis. Okay, does it have CNS cover, fluconazole? So what is the drugs available for CNS fungal infections? Guys, you need to answer. Can we give echinocandins? Please read up, okay? So definitely you cannot use echinocandins in CNS infections. Okay, so definitely it is not going to penetrate. Okay, so the drug levels of echinocandins in CNS is not there. So you cannot use your caspofungin, anidulafungin, etc. in your CNS infections. The probable drugs which are going to be effective is your azoles and
Flucytosine.
Flucytosine. Excellent. Okay, so these are the group of drugs. So azoles are ineffective against Candida glabrata and Candida krusei. Okay, so these can be affected by echinocandins. Okay, so if a patient develops urosepsis, okay, so what is the drug of choice? And the sensitivity is there for voriconazole, fluconazole. And obviously caspofungin, amphotericin, everything is there. Can we use azoles in UTIs? So the drug levels of azoles, especially voriconazole, is very less. Okay, so probably echinocandins are still better. Okay, so please remember that. Okay. So posaconazole, after the recent COVID thing, I think so this has gone up, especially because IV versus oral, all of this was a big debate. Okay, remember it's a triazole antifungal. Okay, again it acts by inhibiting the enzyme that is 14 alpha demethylase enzyme. Okay, and it breaches the cell membrane integrity, ultimately causing the break of the fungal cell wall. Okay, so adverse effects include hepatotoxicity, long QT syndrome, hypersensitivity reactions, etc. Okay, so echinocandins, it is a fungal cell wall inhibitor, that is your beta D glucan synthase inhibitor. Okay, it causes loss of cell wall integrity. Okay, the examples are caspofungin, anidulafungin, and micafungin. Usually, it is less responsive to Candida parasilosis. Okay, remember echinocandins are poor CNS penetration. Okay, majorly you cannot use caspofungin in patients having liver dysfunction. It is known to cause transaminitis. At that particular time, probably anidulafungin is a better drug of choice. Okay, so these are basic few questions on antibiotics. Definitely, I'll not be able to do much. The only thing is I wanted a good interactive session. Okay, let's take imipenem cilastatin for that matter. So why is cilastatin added for imipenem?
Urinary inactivation of imipenem is prevented by cilastatin.
How?
Enzyme dihydropeptidase.
Very good. Dehydropeptidase 1. Okay. So that is prevented by the addition of cilastatin. Okay. So that is one thing. So remember all these smaller things. Which carbapenem has the highest seizure threshold? You know, carbapenem causes seizures, right? Which has the highest?
Imipenem.
Ertapenem, imipenem,
Imipenem.
meropenem. Imipenem. Okay. So you need to know all these smaller things, which are very favorite questions of examiners. Okay. Try and present it to your fellow batchmates or juniors or your consultants on a daily basis. Pick up one or two drugs, so it will become more easier. Okay. So earlier, one of you were mentioning that we use clindamycin for necrotizing fasciitis. Okay. So usually what we do is we add peptaz plus clindamycin. Okay. So why do we do this? Even though there is peptaz, which is good enough anaerobic cover, it has good sensitivity to both gram positives and gram negatives. Why do we need to add clindamycin? And there's vancomycin also here, like additional for gram positive.
For the Clostridium organisms.
See, you have good enough cover here. So even if there is Clostridium, I think so the others are covering there. So why is it that is required to add a clindamycin? What is the superiority while adding clindamycin? Okay, has anyone understood or heard of eagle effect? So I'm not telling every skin and soft tissue infection we need to add this. Specifically, we are talking about necrotizing fasciitis. Okay, so what happens here is your BLBLIs are going to make the bacteria go into a state of arrest, cell cycle arrest. Okay, so they're going to inhibit and they're going to stay in that stage because there's excessive production of exotoxin. So this exotoxin will cover the bacteria and it will form a protective barrier against them. And to remove this toxin, we need to use clindamycin. Okay, so this is what is the use of clindamycin in a necrotizing fasciitis picture. Okay, it is just like you're going to battle, and the bacteria has become very smart here. Okay, because of the use of BLBLI, they go into a stationary growth phase. BLBLI will act only if it is in the log phase, that is multiplication phase. If the bacteria is in multiplication phase, only then your BLBLIs will work because they are cell membrane synthesis inhibitors. Okay, so if it is not growing, so bacteria is smart. It will not grow. It will becomes static. Okay, and the same time, what it will do, it will start producing exotoxins. Okay, so this again will give us dual protection. To offset this problem, we need to use clindamycin. Okay, so this is known as eagle effect. Read about this. It's actually a very nice thing. Okay, 45-year-old diabetic male with early septic shock and normal creatinine. Okay, started on standard dose of vancomycin. After the test for 48 hours, it comes as subtherapeutic level. Why might this be?
Augmented renal clearance.
Good. Okay. So where do you see augmented renal clearance?
Especially during septic shock when the patient have hyperdynamic states.
Okay, sepsis, burns, trauma. Okay, most commonest places where you see burns and sepsis. Okay, you remember these two group of patients. Good. Okay, so elderly patient with acute kidney injury on cefepime begins exhibiting non-convulsive status epilepticus and myoclonus. What is the pharmacological reason for this, and how should the dose be adjusted?
Cefepime lowers the seizure threshold, and
So,
it needs a renal clearance.
okay. So it has actually correct. So usually what happens, it's excessive accumulation of cefepime which happens, and it causes the blood-brain barrier. Okay, so it actually does not lower the threshold. On the contrary, what it causes, it causes hyperexcitability. Okay, so this is called as cefepime-induced encephalopathy. So whenever your patient is on cefepime, watch for patient developing AKI. If the patient is on AKI, like earlier on when we were talking about BLBLIs, etc. and all, right? So please keep this in mind. Okay, if AKI is there, probably better to avoid this because it increases the seizure threshold. Seizure propensity, not the threshold. I'm sorry, we cannot use the word threshold there. Okay. So it directly causes this because it inhibits the GABA receptors. GABA is usually the one which causes or prevents seizure activity. Okay. So sepsis causes massive capillary leak, etc., which usually like if you're taking hydrophilic group of antibiotics or lipophilic group of antibiotics, usually which one requires higher loading dose?
Hydrophilic.
Hydrophilic. Why?
Because there will be a lot of third spacing of the fluids, so the volume of
Volume of
distribution will increase.
distribution will increase.
Correct. Okay. The answer we are looking for one word is volume of distribution. Okay. So usually hydrophilic drugs, larger volume of distribution. That's the reason we give loading doses. So if someone asks you which group of antibiotics you want to give, what is the clinical context, you need to tell this. Okay. Usually hydrophilic drugs are the ones which require a loading dose more than a lipophilic drug. Okay. So why is intravenous vancomycin ineffective for treating C. diff colitis in a diabetic ICU patient when preferred, and what is the preferred route of administration? Last question.
Because of the bioavailability, the overall bioavailability will be more for C. difficile colitis.
Mm-hmm. So usually when you're giving IV, right, that does not reaches the other thing. So basically you can tell whatever you told is quite acceptable. Okay. So the uptake itself will not be happening. Okay. It does not reach the intestinal lumen when you're giving it IV. So you have to give an oral drug itself. Okay. So you need to know the standard dosing for C. diff for vancomycin. What is the
250
standard?
milligram.
250 is what we are getting.
QID.
But what is
125 mg Q6
125 QID.
very good. Okay, 125 is what is the IDSA and all. This is what they are saying. Okay, 250 is what we are getting. The oral preparation, what we are getting in India is mostly 250. But the recommended dose is that. What are the other choices for C. diff? What are the other drugs which are available for C. diff?
Yeah,
Metronidazole,
Metronidazole is
Metronidazole.
available.
Fludaxamycin.
Fidaxomicin. Okay, so
Fidaxomicin.
any monoclonal antibody for C. diff, you guys know?
Methoxyl,
Uh-huh. It's called as bezlotoxumab. Okay. Okay, fine. So there's so much to discuss. Okay, but I think so I'll be winding up with this because I've exceeded. Okay, so I think so next you guys will be quizzed upon ABGs, which was pending. Okay. Anything else? What I want you guys to do is please go back. The thing is, more you answer, more you'll know. It's really difficult for us to teach every drug. Okay. Only thing is, you need to know a systematic way to approach. Firstly, you need to know what class of antibiotic they belong to. Okay. What is the coverage, whether it is gram positive, gram negative? What is the standard dosing, PKPD principles, adverse effects, and any trials that you know of. Any trials that you guys know about continuous infusion versus bolus dosing, especially for BLBLIs and
Mercy
carbapenems?
trial.
Mercy, and there's one more. Any difference they found?
No difference.
Okay. There's another trial called as the Blink 3 trial. Okay. So that is one thing. Merino, you guys have already mentioned. Okay. So there are trials regarding shorter course of antibiotics. Okay. So you need to know about that 5 days therapy, 7 days therapy. Okay.
Remap
So
trial.
sorry. Okay, I didn't hear that. Okay, so you need to know all these trials basically when you're sitting for the drug station. Okay, any questions that you guys want to ask? Otherwise, I think so I'm done. Any questions? Okay. I think so most of you have answered in the chat box. That's good. Okay, so that's nice. Jubin, nice, good. So if there's none, I think so I'll ask Niharika to take over. Thank you.
Thank you, Darshan. Especially this antibiogram was very good. I
I
also learned so
hope,
many things.
I hope I'm not confused. I think so you guys have to read that all over again to understand the stepwise approach for antibiograms. It's a little tricky when they talk about, especially the susceptibility testing and choice of antibiotics when we have. Okay. Okay. Thank you. And all the best, guys, for your exams. I think so. We'll not meet in live like this. So keep updated and leave us messages if you have any doubts in the group, if you want any help from us. Okay. So all the best for your exam. Thank you.
Thank you, Darshan. Bye. Yeah, good evening, all. So this will be, I think, around 45 minutes to 1 hour. Okay. We'll solve around, if possible, 15 ABGs or maximum 10 ABGs. Okay. Previously, I have discussed in detail about the theoretical aspect. So now we will be only solving the ABGs. Okay. So one ABG, I'm going to give 5 minutes. You can either unmute yourself and answer it after solving it, or you can put it in the group. So actually, you can compare your answers with your other colleagues if you put it in the chat box. Okay. So before going to the questions, so first we will look about the check the validity for the ABG. So if you have time, you check for the validity. If the examiner at least ask when you answer the question, at least tell that the first step I would like to do is the validity of the ABG. Okay, at least you tell if you don't want to calculate at least. Okay, so then you see the primary, whether it is respiratory or metabolic. Suppose if it is respiratory, you have to check whether it is acute, acute on chronic, or chronic. Okay, and then go for your compensatory mechanisms. Before that, if there is a FiO2 given, please check for the AA gradient. Okay, so this is about the metabolic, respiratory part. So suppose if it is a metabolic part, even if there is a compensatory metabolic acidosis, and if they have given you the electrolytes, please check for the anion gap. Okay, so wherever you are getting any metabolic acidosis part, please check for the anion gap and your delta gap. Okay, so in the compensatory mechanism, you are going to use only your Booston's principles when you're giving into your exams. Okay, otherwise the others are your Copenhagen's and Stewart's approach. At least you should know a little about both of the compensatory mechanisms. Okay, so I think most of y'all have known the formulas which has to be kept in mind, how to calculate acute on chronic respiratory acidosis, right, or respiratory alkalosis. Okay, and all your compensatory mechanisms. Done. So last time I think that I have done only 2 ABGs. So, but still we will go with the remaining ABGs now. Okay. So, okay, we'll go from the starting one only. Okay, shall we start? Are you people ready? So how many candidates? 15 candidates. Okay. So we'll start it and you all put it in the chat box. 5 minutes for each ABG. If you make it faster, it is better. We can solve much more ABGs. Any other people other than Sriram? Okay, likely causes OSA, chronic respiratory acidosis. Amarnath, acute on chronic respiratory acidosis with alkalosis, metabolic, increased AA gradient, hypoventilation. Okay. So, Sriram told chronic respiratory acidosis. Amarnath, you're telling acute on chronic respiratory acidosis. So, what was the ratio which you got? Delta H by delta PCO2? 0.45. Sriram, how much you got? Any others? 15 people. At least you should solve so that this is the again you need not to go for the ABGs to solve. So this 1 hour is very important so that you can become perfect with your ABGs. Okay. Yes. 0.29. Okay. Okay. So it's basically a chronic respiratory acidosis, not acute and chronic. Okay. So your answer would be chronic respiratory acidosis with metabolic alkalosis. Your A gradient is nearly 33. Okay. So the hypoxia is not only purely due to hypoventilation because there is an increased PCO2 and your AA gradient is increased and there is hypoxia. So this is secondary due to either a shunt or a VQ mismatch. And how do you confirm whether it is secondary to a VQ mismatch or a shunt? You give some supplemental oxygen. If your shunt AA gradient improves, then it is secondary to your VQ mismatch. Otherwise, it is a shunt and it is secondary to your OSA because of the history which is there. Okay. If everyone are okay, we will go to the next ABG, or if you have any doubt, please ask. Okay. Second ABG. Okay, it is metabolic alkalosis with respiratory acidosis with a gradient of 17. Okay. Metabolic alkalosis with compensated respiratory acidosis. Okay. So it is primary is metabolic alkalosis. Your compensatory is coming around 54.6 if you calculate exactly with the formula. So it is slight amount of respiratory acidosis is also present. So your A gradient is very good. Absolutely. It is 17, which is just above a normal for an elderly person. Okay. So, and this is secondary to your hypoventilation. Okay. So I think till this we have solved last time, but now coming from this. Okay. This is very, very important. So here two ABGs they have given at 7 a.m. and 10 a.m. And it is a 15-year-old male who has been receiving treatment for asthma in the ED for about 3 hours. The patient has persistent hypocapnia. He is now tachypnic with mild respiratory wheeze, and the following are his serial ABGs. So now what they asked is you need to calculate and interpret the respective AA gradient. So at 7 a.m. what is the AA gradient and at 10 a.m. what is the AA gradient? And you need to describe even the acid base status at both the 7 a.m. and 10 a.m. Okay. So this might take some time. We solve it and put it in the group. With you even I am also solving. 7 a.m. A gradient is 239. Okay. So 319. Okay, good. So your A gradients are nearly equal. Good. Now, can you calculate the acid base abnormalities at 7 a.m. and 10 a.m.? Mm, 13, 18. So what is the 7 a.m. Acid base interpretation? Seven a.m. is respiratory alkalosis with metabolic. Perfect. Right. Okay. Okay. Next is 10 a.m. First is valid A gradient 239 respiratory alkalosis with partial compensation. AG elevated, mixed, increased, unmeasured. Okay, 10 a.m. is respiratory alkalosis with metabolic acidosis. Okay. Okay. So let's see the answer now. So A gradient 239 to 144. So it's been improved. Okay, which indicates that there is lowering of VQ mismatch or the shunt which is there after your basic treatment that you are given to the patient. Now at 7 hours, so everyone was correct. It was a primary acute respiratory alkalosis with complete compensation which is present. But at 10 hours, this has changed to a dual acid base disorder. So now, as I think who has answered that respiratory, yeah. Yes, Bhavesh has answered it rightly. So it is respiratory alkalosis plus a metabolic acidosis with a raised anion gap of around 20. Okay. So if here any doubts, please let me know. Pure Hagma valid protein respiratory alkalosis plus metabolic acidosis 20. Perfect. Very good. Very good. Okay. Okay. So now question 4th. So here is a 22-year-old woman with a 33 weeks pregnant who met with an RTA. So she has a rib fracture for which she received some analgesia and she's vitally stable. Her abdomen is non-tender. Now they have done a ABG which is as follows. So you need to describe the acid-base status of this patient and you have to calculate and interpret the AA gradient. So please go through the question properly. It is a pregnant lady. No answers in chat box. Okay, what is the primary abnormalities that is present in this patient? Respiratory acidosis with metabolic alkalosis. Okay. A gradient 153, 156. Okay. Metabolic acidosis with respiratory compensation. Okay. So I got two different answers. The primary Sriram told here is respiratory acidosis, and Bhavesh you're telling metabolic acidosis. So which is the correct one? Okay, Sriram, why did you tell it is respiratory? PCO2 is within the normal range. Okay, here the hint is she's a pregnant lady. So for a pregnant lady, what amount of PCO2 is a normal PCO2 that you usually take? Percentage changes. Okay. So what did the percentage change that you got here? %, 24%. How 30 to 35, correct. It's 30 to 35 and here it is 42. So it is way more compared to your bicarb, which is just little abnormal, just 1% mostly abnormal. 24 to 26 we usually take here, it's just 21. But the PCO2 rise here is 42, which is way more than the normal rise in a PCO2. Okay, so that is one thing. But this percentage change, actually, I got the opposite percentage change. So for the bicarb PCO2 percentage change, what did you do? So it will be 42 minus 40 divided by 40, if I'm not wrong, right? And for bicarb, it is 24 minus 21 divided by 24.
For the bicarb, the percentage got was 12.5%. And
Okay,
for
that is 3 divided by 24.
yeah,
So how much it will be? Around 0.1 something it will be.
12.5%.
No, you should not. Okay, 12.5%. And how much you got here?
5%.
Ma'am, for PCO2
Uh,
actually,
Yeah, it is 5%. Okay. So ideally, this should be a metabolic acidosis, right? Because which is more, you should consider that. You're right. So
yes,
here
ma'am.
you got 5% for respiratory. For metabolic, you got some 12.5%. So ideally, which is the higher percentage that you need to consider it as a primary, right? According to the thing that we have discussed previously.
Yes,
So ideally, this should be metabolic, but that is the thing that in the first slide, which I mentioned, that history is very, very important. If this was not a pregnant woman, then your answer would be a metabolic component as a primary thing. But since it is a pregnant woman whose PCO2 should be ideally 30 to 35 and they are more, and it is 42, that is more than 7. Okay, so ideally, according to the history, this is a acute respiratory acidosis with a metabolic alkalosis, which is going on in this patient. Okay, so that is also very, very important. So 5%, 12.5% CO2, HCO3. So here it is, acute respiratory acidosis. So as the explanation they have given very nicely. 32 weeks pregnancy, the normal PaCO2 is 30 with a compensatory bicarb reduction. So here she has acute CO2 retention due to pain and narcotics, giving the appearance of an uncompensated metabolic acidosis. However, this must be interpreted in the light of normal changes of pregnancy. Okay. So please keep this in mind whenever there is some word like pregnant woman which comes in an ABG. Okay. So that is the reason I have just kept this ABG, because this is a little bit confusing. Okay. So if you have understood, we'll go to the next ABG. Sorry. How come HCO 321?
Ma'am, how come bicarb should have increased, na, acute respiratory acidosis in last case?
So first the one which will act is your respiratory compensation, right? Your bicarb compensation will take a lot of time. So this is within some time. So they have done that immediate ABG which they have just received. I think that is why it is 21. Okay, it is an acute one. No, in acute one you won't see that much of bicarb raise compared to your chronic.
So it should have been normal, isn't it?
It's mildly reduced, right? It's just 22 to 24 is the normal here.
Okay, ma'am.
Okay, it's just 21. Okay, a slight reduction. Okay.
Okay, ma'am. Thank you.
Okay, so next ABG. So 45-year-old male, alcoholic, treated with flucloxacillin for multiple staphylococcal lung infections. Okay, and he has been improving despite continuing fever and muscle aches, requiring a regular oral paracetamol. After 3 weeks, while still in hospital, he becomes unwell again, and that time they have done one ABG, which is as follows. So, describe the acid-base disturbance. What is the likely diagnosis? What are the predisposing factors here? And how do you diagnose or how do you confirm this condition? Okay, so first we will do two things, acid-base disturbance and the likely diagnosis. Very good. Compensated metabolic acidosis, HAGMA plus NAGMA. Okay. Just mention your delta gap also so that the others also will be able to understand. So what is the delta gap you got here? Delta, delta. Delta ratio is 0.1. Okay. 0.9, sorry. Yeah. Okay, so what is the likely diagnosis? So everyone is are fine with this HAGMA plus NAGMA and compensated metabolic acidosis. Any different answers? I will keep the chat box little side. Okay, I think. So, okay, what is the likely diagnosis? Anyone? So, lactates are 1.3. They have mentioned something about the osmolar gap. Starvation ketoacidosis. Okay. So this is little bit of different one, not so easy one to answer. So yeah, everyone is okay with severe compensated metabolic acidosis with markedly raised anion gap, HAGMA plus NAGMA. Perfect. So here the cause is pyroglutamic acidosis. So what do you mean by pyroglutamic acidosis? Any idea? Anyone? Low glutamate stores leading to acidosis. Okay, good. So it is basically, if you tell, this is one of the most common cause, not most common, but one of the cause of your high anion gap metabolic acidosis, especially seen in those patients who take actually long-term paracetamols along, especially in a malnourished place. You told that there is low glutamate stores. Yes, in malnourished individuals, there will be low glutamate stores, or those patients who have a liver or kidney issues, or patients who are with medications like your flucoxazoline, or rarely you have this vigabatrin, which is one more drug which causes this. So this patient, he was on flucoxazoline, and because he has persistent fever, he was on paracetamol, and both of these has led to his pyroglutamic acid acidosis. Okay, so the best way to screen this, you need to do a urine screen for presence of any organic acids. Okay. Okay, next ABG. So 18-year-old woman suffering from ARF owing to, acute renal failure owing to rhabdomyolysis is vitally unstable and has been undergoing your CBB HD for 8 days. Okay, so describe the acid base status and why is the, okay, first you describe the acid base status. Okay. Compensated metabolic acidosis with respiratory acidosis. Metabolic alkalosis, respiratory acidosis. Oh my God. Okay. Correct. Metabolic. Oh, sorry. Shriram has written as metabolic alkalosis. Good. Okay. So, yeah, metabolic alkalosis, respiratory acidosis. Okay. So the second question is, why is the anion gap not elevated despite your hyperlactidemia? So what will be the anion gap here? It's valid. Metabolic alkalosis, base deficit 5.5. Anion gap is 10, normal. Okay. So Jaideep has already given our answer. Corrected anion gap was 14.5. Jaideep, why did you do a corrected anion gap? What did you correct here? For what you have corrected? Albumin 2.2. Okay. So can you anyone tell me, or Jaideep, you can tell actually. So for every one decrease in albumin from 4, what should be that? 2.5 factor. Perfect. Okay. That's next. So we'll totally solve some 12 at least. So this is the 7th ABG. So a 30-year male presents with fever, vomiting, sweating, confusion, and agitation. Describe the acid-base status and 2 possible diagnoses. Metabolic acidosis with respiratory compensation. Okay. Okay, since it is a metabolic acidosis, so anion gap is 15. So what is your delta ratio? Delta ratio is 0.9. So whenever you're telling metabolic acidosis, you should mention whether it is a high anion or a normal anion metabolic acidosis. Okay. So Hagma plus Nagma. Good. So metabolic acidosis, which is both high anion plus normal anion metabolic acidosis with respiratory alkalosis. So two possible causes they were asked. So one they told post-ictal, because of seizures. Any other? Sorry. So fever, vomiting, sweatiness, confusion, agitation. Delta ratio is 0.375. No, I need to calculate now.
No, ma'am. 37.5 is the percentage.
Sorry.
37.5 is the percentage change in both respiratory component as well as the metabolic component.
Okay. You have calculated both of it because pH is 7.4. So when pH is abnormal, only when your PCO2 and bicarb, you will get the confusion, and the pH is abnormal, then you need to calculate your percentage difference. Now, this delta ratio I didn't understand. Delta ratio 0.375 is? Delta ratio is basically for your anion gap. Delta anion gap divided by delta bicarbonate. Is that 0.375? I think it is 0.9, if not wrong. Okay, perfect. Okay, so next question.
Ma'am,
60-year feed. Sorry.
I have a question regarding the last one.
Tell me, ma'am.
Yeah, the pH is 7.4. So it's a normal pH. So how will we decide which one is the dominant one? Because the percentage change, we'll have to calculate the percentage change, right, in this case.
Okay, if you calculate the percentage change also, which is coming first, which is coming more?
Both of them are coming same, 37.5.
Because see, the thing is, you calculate the percentage difference only if your pH is abnormal and your PCO2 and your HCO3 will go into the same direction.
Okay.
Okay, so in this, okay, so when it is 7.4 and your history, now coming to your history, what does the history is mostly suggestive of? Fever, vomiting, sweating, confusion, agitation. And there is a hypoglycemia, severe hypoglycemia, which has happened here.
Yes.
And your SBE is how much?
Minus 10.2.
So, in which case will the SBE will be so bad? Respiratory or metabolic?
Metabolic acidosis.
Correct. So, metabolic. So, whenever there is some confusion, there will be a hint that will be given to you. Okay. So, here, important is your history and your standard base excess, which is there.
What is the possible diagnosis?
Hello?
Possible diagnosis?
Yeah. I'm sorry. I forgot about this. I think whoever had the doubt, did you understand, ma? The standard base excess is a hint here, and there is fever, some sepsis, which is going on.
Yes, ma'am.
Okay. So here the acid-base disorder is in combination with hypoglycemia, correct? Which is seen in conditions such as there could be a salicylate poisoning, there could be a sepsis, there could be a fulminant hepatic failure with lactic acidosis. So these are only just the differentials which we are giving for the hypoglycemia that is presenting with a metabolic acidosis. Okay, so hypoglycemia, metabolic acidosis, for us the first thing is sepsis with septic shock. Second, this can also happen in your hepatic failure. Third, in certain poisonings. So any of the poison, high anion gap, metabolic acidosis, so many poisonings are there. Which causes hypoglycemia is your salicylate poisoning. Okay? Next. So pneumonia, shock, and respiratory distress. Wake up 10 plus 8, 23, 21, 25. Okay, so since they have not given any data for further calculation, so what would be your primary thing? With compensation, metabolic acidosis with respiratory acidosis. Absolutely fine. So they've asked, is there a problem with pulmonary oxygen transfer for which you need to calculate the A gradient? Oh, he's going into respiratory acidosis. So A gradient is 213. Is everyone fine with Bhavesh answer of 213? So 0.5 into 713 minus 30 divided by 0.8. Yes, 213. Perfect. Okay. So is intubation likely to be necessary here? So Shriram, who told yes it was necessary? Yes. So shock, there is respiratory distress. Okay, there is respiratory acidosis which is also present. So you require a intubation here. Perfect. The next one. So a prisoner is pulled unconscious from his cell after setting fire to his mattress. He has minor superficial surface burns. Okay, so your barometric pressure, they have given FiO2 0.4. SaO2 is 96%, pH is 7.26, PCO2 30, bicarb is 13. So what are the acid base abnormalities? A gradient, and what is your likely diagnosis here? Compensated metabolic acidosis. Perfect. With respiratory compensation. Okay. A gradient is 247. It is 0.4. 0.4 into 713 minus 13 plus 0. Hypovolemia. A gradient is 247, huh? Any other answer for the A gradient here? Yes, correct. 187. From 247, you need to minus your PO2s here, PaO2s. So 247 minus 60. So it is 187. Good. Okay, what is the likely diagnosis? Ideally, this patient should have a raised PaCO2, but here it is a metabolic acidosis. So one is your hypovolemia, and any other differentials? Yes, perfect. Either it is carbon monoxide poisoning or your cyanide poisoning. That's good. Okay. Last three. 10th question. So I actually request you to try solving it without a calculator. It would be a better option because you won't get a calculator in the exam. So I hope you people are solving it without a calculator. If it comes nearby also, it's not a problem. You need not to have an exact value. Nearby value is also fine. So please calculate it without a calculator. So the following is a VBG from a man who has been treated for accelerated malignant hypertension. Okay. Hint has been already given for y'all. FiO2 is 0.21, pH is 7, PCO2 is 25, bicarbonate is 6. Okay. 6 plus 3 plus 5. Complete. Metabolic acidosis plus respiratory acidosis, perfect. That's right. Mm, 49 minus 31, around 30, 30. So, 111 minus 75, 4, 12, 40, around 44. So what is the A gradient you people got here? So metabolic acidosis with respiratory invasive mechanical ventilation. Okay. NIV, temporary bicarb infusion, and eventually RRT intubation, invasive mechanical intubation. So why do you think there is that severe metabolic acidosis here? They're asking what is the likely mechanism for such a bad metabolic acidosis? Renal failure. Any other thing? There is a hint which has been given in the question. DK, notes. A gradient 44, 45. Yeah, correct. Nearly. I just calculated around 44 to 45. Good. Okay. I want the answer. Who will answer? Why is the metabolic acidosis so bad? Okay. Okay, so this patient has been treated for accelerated malignant hypertension. So it has been secondary to your sodium nitroprusside, which you have been given to treat the accelerated hypertension. Yes, patient Anshul has answered. So it is sodium nitroprusside induced cyanide toxicity. So your treatment would be, see, so different. So now you know how to solve the ABGs, but you know to interpret why is that so. Okay. So you should administer basically the antidote for your cyanide toxicity. Done. So one more question which I will give you. This is like a who is going to solve it first? Okay, so what will I give? Just wait. Do this one. Okay. Okay, solve the last one we will solve. Okay, solve this. So we'll see who is going to give me the complete answer. Okay, describe the ABG finding and what is the reason for respiratory acidosis here they've asked. Complete answer, who is going to solve first? Okay. Respiratory acidosis with metabolic acidosis, pure hugma, delta ratio 1.5. Okay. What type of respiratory acidosis is it? Bhavesh, acute and chronic or chronic? Acute. Okay. So what was the value that you got? Acute. Okay. So here the PCO2 is 78, bicarb is 16, and pH is 6.95. So I think first you used your percentage gap. So in the percentage gap, you have finally confirmed it as respiratory acidosis. Now for respiratory acidosis, you need to see whether it is an acute or chronic. So what is the value you got for acute and I got acute and chronic 0.78 I got. How much you people got? What was the value for your calculation of acute respiratory acidosis? It was more than 0.8? Can anyone unmute yourself and tell me how much you got? You got more than 0.8. Okay. How did I get? Very wrong answer. 95 minus 80 is 15.
Ma'am, here since the pH is 6.95, will that formula be applicable? The decimal is after 6, not after 7. That 80 minus point whatever is after the decimal.
No, actually, they tell it is after the decimal point, whatever it is. Suppose, okay. Why, if in that confusion,
Because
so
if we even take it as 7.0, the delta
yeah.
H will come 80 minus 0. It will be 80. It is 6.95. That means it will be more than 80, the delta H. Hence, making
Correct.
the delta H by delta PCO2 more than 80 divided by 38, which will be very high, more than 2.
Okay, you got here 6.95, no? Okay, just wait a minute. We can actually check exactly 6.95. What will it correspond to? So your hydrogen ion will be how much? 112. Okay, so if 112 minus 40, how much it will be?
72.
So 72. Okay. Now 72 minus 40? No, 72, I mean, correct. So you got already 72. So 72 divided by 32, how much it will come?
It will be more than
2.25.
2
So
only.
it is acute only. Right. Okay. So only if it is more than 7 point, then only it will be able to do. Otherwise, I think you have to go for your pH table, which is there. Okay. Otherwise, the best way to calculate a hydrogen ion is your modified Henderson's equation. So less than 7 point something, you go to calculate your H plus ions by using your Henderson's equation. Okay. That is the only way that you can do. Okay. Okay. So it is acute. Next. So what was the question? I'm so sorry. Shit. Okay, perfect. So it is acute. Adjust ventilatory settings. Very good. Should go for high PEEP and low. Okay, good. You should treat like a ARDS. Here the settings were very wrong. That is a reason for respiratory acidosis. Okay. So one point to be kept in mind, when the pH is less than 7, try to use your Henderson's equation to get your H plus ions and then calculate whether it is acute or chronic. Okay. Or if you want to try once, you can try with this Henderson's equation, calculate and see whether it corresponds to the same thing. Okay. So you want to continue it or we'll just stop it here? I think most of the ABGs you have done now, you know. So when to calculate the percentage difference, how to calculate acute on chronic, compensations, anyways, you people know it. So whenever metabolic acidosis comes, please calculate the anion gap and your delta gap. And please go through the questions. In some situations, when the pH is normal, see for the base excess, read for the question, accelerated malignant hypertension. So what could be the cause? Okay, so your history is also very, very important. Okay, ma'am, can you share the PPT on the group? I think PPT sharing, I think it's not possible. I'm so sorry. I think only the recording sessions will be available for you. I'm very sorry. I think we shouldn't share the PPT, but I'll just confirm it once and I will let you know. Okay. So my sincere request is just keep, because now you are okay with this, solving the ABGs because you know the formulas and all. But after a week or 10 days, you might forget it. Okay, so just hold your junior, try to teach him this so that you will keep it in mind, and just make a small, that as I told here, this is the how to solve the ABG, just one slide which is there. So this one. So just take the slide from the recording, put it on your wall, stick it somewhere, and just daily or alternate day, just go through it, how to solve, so that you won't forget it. Okay. So I hope this was helpful. If any doubts, you can personally message me. Okay. Okay. Shall we end the session now?